speakers in the session, which is even the last day of the session. So we'll be coming up one after another. So may I request Dr. Badrinath Rathi will be speaking on the cricket sports injuries. So to let you know, Badri is one of the topmost physical physiotherapist in the country who is working at Delhi District Delhi Cricket Association, and you will be happy to know that he is an ultra trail marathon runner who runs almost 100 kilometers. Thank you, Badri. I
Thank you,
think
sir.
you're the biggest.
Thank
So
you.
when the team physio of the Delhi is for last 15 years, he is the team physio for all the Ranji matches. He is the medical coordinator of ICC Cricket World Cup for the year 2011. Represented India as a team physio in football, volleyball, kabaddi. Indian sprint team athletes who participated in the Melbourne Commonwealth Games and Athens Olympics. And to his credit, he also worked with Sania Mirza, the legend in the tennis. Present designation, he is working as a sports physiotherapist at DDCA, Delhi. So without taking much of your time, I think everyone is eager to really listen, Mr. Badrinath. Over to Badrinath, please.
Uh,
Subirji, you would be host onwards, and I'm here to help you out. So I'm shifting this hosting to you.
okay.
Yeah, please. Yeah, Badri, please go ahead.
Yeah. Thank you so much, Dr. Vikramji, for giving me this opportunity. Thank you, Dr. Devnathji, for this wonderful introduction. Okay. Mm, so today's lecture is about the cricket sport specific injuries. Okay, this lecture is presented based on my personal experience. So it is written in a flow at a go rather in a regular academic format. So please accommodate me for that. So it does not provide complete assessment details. Rather, it touches on the types of clinical conditions seen in cricket by the author. That's by me. So please listen to this lecture in the context already built by the excellent previous resource persons on sports medicine or injuries since the start of this course. Because I'm not going to repeat many things. We are not doing individual joint examinations. So the already context that is laid in the previous lectures that's going to greatly help this. Okay, cricket, as we see, is cricket is a running based sport and it's a skill dominant sport. So cricket is an asymmetrical sport, as we know. So beware of anterior or posterior dominant athlete. So like some are like quadriceps dominant or hamstring dominant athletes in their training. So that we need to identify. So gender, the injuries are different for the male and female. Their anthropometric body types are different, so that accordingly their training is also different. So we need to understand this. We cannot train all of them in the same pattern, on the same manner, in the same loads. Okay, so we need to consider the age. Again, the injuries are different for the pediatric and adult also. So generally when we speak about injuries, we always perceive or think in the frame of adult only. Okay. So there is a difference, huge difference, pediatric and adult injuries, as we already know and already said, already discussed. So let's take an approach of moving from a bigger picture to a specific approach. And we got to be really good in differential diagnosis and from medical disorders. This is very important for physios. Okay, so always rule out the causes of radiating pain, referral pains. Always be aware of losing weight, night pains that disturbs you to get up, or subtle chronic symptoms. Okay, I'm referring to the general health. So for example, someone is complaining of a breathing problem and has since 6 months has lost weight of 3 to 4 kgs in 1 month, and later diagnosed as a lung cancer with tumor kissing the aorta. So we cannot afford to miss, or sometimes we may have to face these kind of situations. May not directly relate to the cricket, though. So the process of attending the athlete in cricket is Generally, we have a medical examination as athlete reports. So it comprises of sports medicine team, and after that we do assessments done by the sports physiotherapist and the sports science specialist, and all the reports finally are discussed with the coaches. Then the game starts, the skill aspect. So sports physiotherapists get along with the neuromusculoskeletal screening of each player. There are psychological assessments done. Sports physios traveling with the team are generally ACLS and ITLS certified, Advanced Cardiac Life Support and International Trauma Life license. Okay, it covers sports first aid, price, protection, okay, dressing, etc. So for the on-field emergencies, we need to have a good medical team support, and team physios should be generally trained. We should be particular about head injuries, concussions, life threatening, and we should always know about the rules of the sport. Okay, and accordingly cricket rules are being changed or updated. One of the first injuries that, the rules that are changed, the changes in the stadium are happened in keeping in mind the injuries on the field is in New Zealand, I guess. That is regarding the change, keeping the distance between the boundary line and the audience. So I think that is one of the first changes has made. So we should be aware of general health, nutrition related, and health related, heat related injuries also. Workload management is a big trend. So rotation policy, as you know we see, okay, with regard to the workload management also to protect the players, prevent injuries. Okay, so now we are coming to the what are the cricket sports injuries. Okay, in general, we should consider the sports equipment also. So as we know now, helmet modification is done. Okay, the front grill to save the face or teeth, which is already there. Now there is an extension of the posterior inferior part of the helmet to protect the upper cervical spine and cerebellar areas. Okay, we are aware there is a death case happened in Australia. Okay, after that, this adaptation of the sports equipment is done with regard to the helmet. Okay, so there are guards, gloves, good quality gloves to protect the fingers, shoes with related to the ankle impingement. So low cut shoes and high cut shoes, uh, there is a difference and how they work because they restrict the ankle range of motion, and so the elbow, thigh, and chest guards, etc. So cricket sports injuries. Okay, so now how I presented is I went on keep on writing this, and in between with specific regional conditions, I have written my case studies in that in the form of a story. I hope it will be interesting. Okay, so first one like is the shoulder, the rotator cuff. It may be muscle, tendon. There may be strains, tendinosis. These are very common. So tears, there may be partial tears or complete tears. There are different types, and the articular, okay, and surface, etc. uh, so it can be because of overuse or chronic or just by trauma like history of fall on the field. During the fielding, you can see like while you can roll over, and especially wicket keepers have to jump and land a lot. uh, Generally we see a cuff primarily as a stabilizer even though it helps in movement. Okay, subscapularis, I guess it contributes to 60% of stability of GH joint. One of the, if not 60%, at least is a very important, it has a very important role to play. So generally we can go for resisted contractions. They are painful. If it's muscle, contractile tissue. So there may be chief complaints like in like pain in the throat or in the bowling. You can notice like wasting if it's a chronic, and always look for the site of pain. It changes the diagnosis and the tissue involved. General investigations, musculoskeletal ultrasound and MRI, and even before that is the sound clinical assessment is the important thing. So mostly exercise rehab plus medical treatment along with the sports physician. Generally, a rotator cuff more than 1 centimeter, tear of more than 1 centimeter, maybe we have to look for a surgical thing. Yeah, and especially if it is a young and traumatic case. Cuff function is influenced by cervical spine, thoracic spine, and scapulothoracic joint also. scapulohumeral rhythm, etc. So may present along with the slap or posterior superior labral tear, internal impingements, etc. So we have to think, see the patient in the whole. Again, shoulder now comes to labral slap anteroposterior with or without long head of biceps involvement, the impingements, bony lesion, hill sacks. So these all these conditions we do see in cricket. So it may be of chronic overuse or trauma, and I guess 30 to 45% of labral tears can be managed conservatively. We have to take opinion of surgeon. Uh, so there may be complaint of pain or stiffness in the early stages. We have to pick at that stage. It may not be a clear cut presentation, but a patient player always comes with kind of a discomfort. So we have to be always to be alert and due diligent. So there are apprehensive movements like abduction, external rotation at 90 degrees or more than 90 degrees. Pain, they can complain of pain in the lateral shoulder, posterior superior shoulder pain, or anterior also. So anterior apprehension, and you can always sometimes see, reduces with anterior and posterior glide of the humeral head. So we have, for example, we have one fast bowler like under 19. I'm not sure whether it's the overuse of trauma, but we managed it conservatively. So his main complaint was pain, like unable to do an overhead throw. So, but the story was that we made him available for selections in less than 2 weeks. So, and he took 8 or 9 wickets in the Ranji match, and he selected for India for the ongoing home series against Australia. But that gentleman, that boy, today he has completed 100 tests. So I'm talking about the story like it was more than 10 years ago. I cannot take names or anything. Uh, but the point I want to stress here is the timely return to competitive sports, and the performance by the player and the motivation of the player is equal to, that which gives the result or the success of the impact. So now we have a player who has played 100 tests, is a fast bowler. Okay, so that is the role of a team physio and proper management and early diagnosis. We almost spend almost like 6 hours a day on one player. So another case, uh, shoulder only, the fast bowler. He has a trauma, history of fall on the ground, and this gentleman, he's also under 19 player. So now this boy has like 280 degrees of labral tear. So before this trauma, he has a history of labral tear in a small arc, maybe 11 to 1 o'clock in between. So pre-existing injuries can aggravate and increase with another episode of injury. So all these cases I have seen, only those I have shared here, rather than I refer to any other source. Okay. Another example, shoulder case, the female cricketer, there's a history of a fall on ground, and investigations reveal there's a bony changes, mild hill sacks type, and posterior superior glenoid changes. Her chief complaint is pain in the overhead throw and apprehension or discomfort in abduction, external rotation movement, and or uneasiness, or feeling of getting stuck. Uh, yeah, so these are the complaints always uh, player complains of, and for them whether it is fine or not is measured or calibrated in terms of this feeling only. uh, if they are not, if the shoulder is not getting stuck, in their own words, they decide that they feel that they're getting all right irrespective of what you do. So that classical comparable signs and symptoms has to be addressed, which is said by the patient, for which the patient or the player consults the physio. Okay, so we have done an isokinetic testing. Okay, then we found the very weak cuff with strength training, the symptoms have subsided, and we actually already started overhead throw also, or like almost like 45 to 60 throws per day, alternate days. It's like it follows a pyramid shape. There is a warm up, as one set of warm up, then different intensities like 45, 50, 70, 80% intensity. Then you reach the peak, you come down, you do a cool down set of throws. That's how we plan a throwing session. Okay, not just like we do like two sets of 15 throws or 10 throws or like that. So there is an increase and decrease in the intensity and volumes of throws when we help them return to sport, if you have to address the overhead throw. So another example of the shoulder. Okay, it's a surgical case for a posterior labral tear in done in the right hand batsman. It is done on the left shoulder. Uh, what we focused on a good recovery on horizontal adduction. Uh, okay, and to get a good flexibility of the posterior capsule, and we gradually progressed on pull-ups from supported to unsupported, and in increasing horizontal adduction angle. So we helped him to return to sport, competitive cricket, international cricket, in 4 to 5 months. So please understand that I'm not going into all the clinical details, but a major directions how a case condition has dealt, how the progress has made, what are the major milestones we have to look for, and or what we have done. So over and the batsman, he has to do mid on mid off. So we have to see that direction. That's why we need the posterior. Uh, it's the leading arm and the posterior flexibility, which is the surgical side. So when we say the player is fit, it's not just about the strength is regained or a pain is subsided or flexibility, mobility has come back to normal to pre-injury status, but we need to consider the skill of the player. So the player will not be happy if he is a batsman, if it's the leading arm, as long as he can play unrestricted shots. So we need to consider the joint in the context of the player's participation, of his context. All the okay. So and generally, in case of surgical cases, also laborals overhead throw recovery, it may take 5 to 5.5 months. Okay, post-op smooth 360-degree movement of the humeral head is a critical to retain the skill. So that's what actually we look for. So it's not just a repair we're looking for, it's the smooth retaining of the skill post-op and post-rehab. So that's our ultimate goal. So another example, shoulder joint, you can have like subluxations, dislocations, instabilities, laxities, depends on anthropometric types. Again, like female cricketers or sportsmen, the flexibility may be more. Okay, they totally present with a different kind of problems. I have to deal with on flight with a fractured, it's a subluxator shoulder, as a stable fracture. So I had to stabilize it. And 4 days later, he's an IIT professor. On 4 days later, he had undergone surgery, and he is fine. But during the flight, we had to manage him. So it's not, I was traveling with my Delhi first class cricket team. Uh, you know, so like that. So another case which I have come across is
Badri, your screen is frozen.
come across. It's
Badri, you have to again share your screen because everything has changed and your screen was frozen in between. And you have to unmute yourself. Unmute yourself, please. Your voice is,
yeah.
yes. So screen sharing, you have to do it again. We are unable to see your screen.
Yeah, I'm doing it
Yeah, please.
now.
Yeah, now this is
Okay,
visible.
okay. So we covered the Glenad Bonilos case, and okay, another case of like shoulder subluxation. We had a player, fast bowler. So he was playing a T20 match. He did a overhead throw like from the boundary line, and he's complained of he unable to lift his arm. Shoulder was clearly subluxated, and okay, after the overhead throw from the boundary line. So like we are given rest for the rest of the tournament. We managed it conservatively. So we returned him to national duty in few weeks with complete fitness. Both the we tested throwing and bowling. And but in this case, he has a history of weakness in the static stabilizers also prior to this injury. So these kind of cases, a team physio sees come across, and unexpectedly things do happen on the field during the matches also. So we have to always pay attention to the history and the pattern of injuries that is happening with the players, and especially if it is a new player, and it becomes more necessary, and we need to understand the player if it is a new player, and we need to know the maturity of the player, also the education level of the player also, and we need to know the language of expression of the player. We are very good at verbal, we are very good at terminologies, but we need to understand the language in which the athlete express his about his discomfort or problem or his needs. They may not from the city, they may not know our language, they may not know the uh, world of the clinicians. So we need to a clinician as a team physio need to understand their language. So this player belongs to that type of arena. So that's one case. So these are the real practical situations or conditions in addition to the just a clinical condition we need to be addressed. So another example, there's a case of recurrent dislocations. There is no trauma or traumatic cases. Okay. So we have to see, does it affect the skill precision in the bowlers or batsmen? Okay. There may be history of fatigue, stiffness, localized fatigue. Okay. The muscular, neuromuscular, the stiffness, if any compensation around the glenohumeral joint, always have to be alert in our and one thing, being a team physio, the advantage is you'll get an opportunity to see your players again and again, before the start of the game, starting of the session, end of the game. So you can always keep telling to the players to look for a few things about the flexibility, soreness areas. So that's how you pick up from the ground, and early, very early, that's how you pick up things, and let not worse. So that leads to the early diagnosis. Okay, AC joint, maybe bursitis, subacromial, etc., along with the impingement or labral tests may not be present isolatedly. So these things do fall collectively in coinciding with the other clinical conditions. So there may be different types of structures, downsloping, type 2, type 3. So in clinical examination, is a very simple routine is a painful terminal flexion may be present with the end range, okay, with overpressure or without overpressure. So now let's come to spine, cervical spine plus temporomandibular joint. So you will come across like cases of rhinitis, spasms, spine dysfunctions, derangements, disc related, that may be because of traveling, sleeping positions, the pillows, or carrying their heavy bags. The neck can be influenced by the lumbar spine. There may be jaw deviations, again because of the lumbar spine, leading to the jaw deviations. Because of the cervical spine, you may find our place with headaches. So we have to differentiate between cervicogenic and migraines. So your sports physician will come a lot of help here. uh, so because the vestibular apparatus is there, the balance is affected. Okay, so we need to address that. So again, cervical spine influences shoulder girdle. Again, it can lead to fatigue, stiffness, pain. So you have to remember why I'm stressing about fatigue, because If it is a spinner, he may have to bowl 30, 40 overs in an innings. Fast bowler, somewhere between like 10 to 20 overs in an innings. So we have to see in that context. So it the fatigue plays a huge role. And if it is in the match, we have to make the player ready for each and every session. So we do not have time. So we need to address it. So and we cannot let affect the performance or neither the skill. So these factors in a day-to-day sporting life plays a huge role. It need not to be any major injury, but these kind of minor hiccups or problems also can cause major problems. Okay. Yeah. Next, come to the thorax and the rib cage. So you can see in some cases scoliosis, facet joint dysfunctions, degenerations. Okay. Side strains are you will come across cases of side strains in fast bowlers, even in batsmen. I have seen a batsman who had a side strain, but ipsilateral hip function is not good. So in combination, I'm not sure how it influences, but we have to pay attention to all these problems, because we even though they come with the problem in one area, but we see the entire body functionally, kinetic chains, etc. Not just kinetic chains, many other things. Okay. Examples: a fast bowler with a history of, okay, this is a very interesting case actually. So he has a history of injuries on one side: the ankle sprains, low back pain, pelvic pain, uh, in landing, extension based, side strain, all these on one side, and the shoulder injury on the other side. So actually shoulder surgery was the first injury. On the other side, that is a bowling arm. So this gentleman has to undergo surgery for pain causing by degeneration of osteophytes around the thorax, okay, thoracic spine joints. So I am unable to recall the exact location, the site. So, but the interesting thing is 2 years or 3 years before the surgery, during one of our tests, he could not do or maintain a lumbar posture. So it leads to pelvic drop while doing a hip flexion on the same side in the all four position. You can test in standing, but what I tested in the all four position, so basically the player has to do a hip knee flexion, maintaining the pelvis in neutral, a lumbar spine in neutral, but that he could not do it. It's a simple movement. So he's fond of lifting weights, and in the present scenario, actually the pain was triggered by a fall on ground during fielding. So what we realized in investigations, he had degenerations, osteophytes, that is impinging and causing a lot of pain around the rib cage. Ultimately, he has to undergo surgery in UK. So this is one case. So we need to pay a lot of attention to very simple exercises, low intensity exercises, to be pain free. That builds the foundation for the high intensity workloads. This is one classical example. So again, you can come across stress reactions and fractures predominantly in 15 to 21 years fast bowlers. Yeah. And okay, it's a repetition. Yeah, spine, the lumbar spine. So actually, the previous point belongs to lumbar area primarily. Uh, so again, here you can see scoliosis, facet joint dysfunctions, disc-related degenerative derangements, stress reactions, fractures, spondylolisthesis, lysis. Few examples: fast bowlers. Whether there is any predominance when there is an order in this, I'm not sure. Like in terms of getting affected more, like fast bowler all rounders get affect more, like all rounder fast bowlers, like batsman dominated, or ball and fast bowler and bowlers and batsmen. I'm not sure if there is any order in that. It's just a question mark. So I have seen in Olympic level sprinters the spondylolisthesis, and again we are not sure it's by birth, early or in the early age, or or developed as they grow up during their training. I was not sure, but when I seen it is there, we left it to the authors. But after that, we did a very good rehab, and the sprinter went on to do well in the Olympics. Uh, and the Olympic athlete, the who got participated in the Athens Olympics, got seventh place sprinter event, and they got a silver medal in the Melbourne Commonwealth Games also. So that's one good experience. So in one another example, fast bowler, there is he comes with like no history of training, no history of playing cricket at the professional cricket at the younger age rather. So direct entry into the first class cricket, no history of playing cricket in there's history of playing cricket, that's in agricultural fields. That's how his love for the cricket started, and expressed his love for cricket. So from there actually he was picked up. So the chief complaint, so this is the typical history of a player. So we can come across world class players coming from this kind of humble origins and context also. So we need to see this context in terms of match preparation and getting ready for the sport. So that's what I'm trying to stress here. So with totally no knowledge, no history of playing the sport, no training at all. So sometimes you do come across some wonderful talent like this. So what happens to those kind of players? So in this case, he has a complaint of pain in the lumbar spine. Um, that was my first match with him. So I did not have a prior history of this gentleman. So during the match, his bowling speed has slowed down during bowling. So it was a morning session, and after bowling just 5 to 10 overs, we got 2 to 3 wickets. We are dominating the match, and all of a sudden his bowling technique has changed, his speed has changed. So in between the match we has to take him for an MR. So it was a classical fracture. It was like acute on chronic. I said it's the acute on chronic, it is already there. Okay, acute on chronic with bone marrow edema. So we pulled out of the match, that player. So decision, team physios, like if team physio does not know the player history before, okay, it will be difficult to diagnose what exactly is happening. If he already knows what is there, he can easily understand what's going on. Okay, so now another in the same situation, now whether the team physio, like he will let continue the player play the match or stop the play. So that's one thing, is a learning point. Okay. uh, Next, player may present with overall player history over the years, like so now in one player you do not see one injury, so you will see multiple injuries. So if you follow a player life cycle, sporting career life cycle, so he may develop multiple injuries. So I'm trying to share here one of those kind of cases. So like right and left, both sides there is a lumbar stress fractures. Left side abdominal strain. So there is a history of ankle injuries. There is again there is a left groin pain, groin injury. Okay, and there is a right shoulder injury. Of course, that was a traumatic on-fielding, so we have managed well with the conservative. Couple of years later, it got subluxated or dislocated. I'm not sure. It's okay. So but we made him fit in few weeks again. So he's playing for senior India. So there is no, it's not so, it's no, it's a no. There is no sequence of injury preference here. So, but I'm trying to present, how we see the athlete. So the biggest predicting factor for an injury is the previous injury. There's as a risk factor. So we need to take care of athletes in all the directions. It's not just injury management, it's like prevention of injuries also, and how they happen. Many times we do not know, but we have to keep probing, querying, doing research, try things out in uncertain areas also. So now another case, a batsman is a predominant selector, is available for selection as an all-rounder, as a batsman all-rounder. So slow medium bowler. He has a grade 2 spondylolisthesis. So we are managed well with conservative management. So his chief complaint always was low back pain. So never had a neural symptoms like sciatica. We are able to manage without any hamstring muscle tears in his career. Let's come to hip. Uh, There can be labral injuries, degeneration, impingements. You can around the hip joint, tendon related, lateral, anterior. You can see like snapping hip, like maybe while doing like single leg standing, hip flexion or abduction. Okay, you got to be careful of femoral neck stress fractures. Stress fractures, I will speak a bit about them. Uh, and lesser trochanter area, greater trochanter area pain. You have to look for gluteus medius, iliopsoas, insertional areas. Okay, so hip stability is very important. The femoral neck area, especially in women. Okay, pelvis, with or without hip area. Again, groin pain. I have come across an adductor related, abdominal related pubic symphysis degeneration case in a fast bowler under 23. So there is a pelvic floor.
Badri, Dr. Badri.
Yeah,
Yes, sound. Yeah, yeah. Now it is okay.
yeah. Okay. So one example is right arm fast bowler, workload related chronic injury, acute on chronic, adductor related left groin pain with edema in the left pubic ramus, degenerative changes in the pubic symphysis. He has a bilateral sportsman hernia, but interestingly, symptoms are present only on the left. Okay. Food for thought. Uh, and he has left abdominal aponeurosis strain, proximal hamstring tendinosis changes. All this is in one case, one player, in one episode. So we are all the squeeze tests positive in the supine, you know, between the ankles. You're testing, putting the pressure in between the ankles, between the knee, and crook lying with the knee bent. Again, like at the edge of the bed, like in a Thomas test position, you're looking for resisted hip extension, abduction and extension combined. So you have to look for the palpation also of the muscle and the bone. So in this case, the pubic ramus symphysis all are tender. So but interestingly, hip is fine in this case, but generally we have to rule out impingements. Okay, and classical movement may be the flexion, adduction, internal rotation. So MR or MSK ultrasound, the good choices. Another case, this is not a cricket case, but it's a football case. Is under 16 boy. So he has in a left is a right dominant. So he kicks with the right leg, and he has approached with the complaint of the left anterior hip and groin pain. So it's more of like a rectus femoris and a sartorius tissue related. Okay, I thought just sharing it here because at present I'm treating that case. Okay, the knee. I have gone through all the backup volumes of American Journal of Sports Medicine of last 50, 60 years. So one thing I able to understand regarding the ACL is to able to control the anterior translation of tibia. Uh, okay, so you can come across IKDs, internal knee derangements, ACLs, complete, partial, trauma, non-traumatic, PCL, menisci injuries, collateral ligament injuries, patellofemoral degeneration related, lateral knee pain, ITB related, cartilage injuries, condylar, patellar facet, etc. Okay. Um so they may present in isolation, or ACL we all know may present with in combination with one or two other combinations. Okay. So cartilage injuries, I have seen a player with a direct hit injury on the ground, the knee banging on the ground, or direct hit injury from the ball. So in both the cases, unfortunately, the player has to undergo surgery. Okay, it's really unfortunate. Uh, okay, ACL. Okay, our experience in an ACL case, a cricketer post-operative ACLR, so we able to manage to put them back in competitive cricket in less than 5 months as a batsman. Now playing at the highest level of competition. I got the ICC Cricketer Award also. It's been 3 years, and there is no recurrence. So we have met the demands of the player, demands of the nation, and it's not an easy. It was a very tricky case, and we are dealt with very nicely. We are so happy. We got to be creative in that path of rehab, and again we were spending like more than 5-6 hours a day in rehabilitating this player. And today that player is still doing well with no any complications or recurrence. ACL present research do say that it may take 8 months or 9 months also. So some may say that this case may be like an outlier case. It is an outlier case. It's a very unique case. I have a player, international test player, who has recovered from ACLR in again in less than 5 months, and they did play well and for a long time with no again history of recurrence or anything. We know that there is a well established and evidence based ACL injury prevention program is there, but may not be cricket specific. Uh, yeah, another scenario, I have come across an under 19 India cricketer now playing for senior India, but he's prone for ACL injury. So I did share my views, and education and prevention is important. So now what happened to this boy? He jumped and landed on the left leg, and he at the boundary line, and he twisted his ankle on the left side. So really unfortunate. There are some things we can always work, but still uh, we never know. Tibia, yes. Shin pains, medial, lateral, uh, stress fractures, running, their load related stress reactions. Okay, let me be very clear. What I am taught or what I learned is high risk stress fractures like these are not the domain of the physios. Sometimes they may not present with any localized tenderness till a particular stage. So for the these may be career threatening. Also, it can lead to a complete fracture line also. So always has to be referred to the sports physician and orthopedician at the very early stage. Otherwise, it can lead to career, as I mentioned here, career threatening or career ending. Again, like similarly, navicular cases, and especially on the tension side, stress fractures, they are very high risk compared to the compression side. uh, Again, there is an interesting algorithm or pathway of deciding among the when to go for an X-ray, when to go for an MRI, when to go for an CT scan, when to go for bone scan. uh, for specificity is the CT, for sensitivity is the bone scan and MR. And again in MR also, the when to look for T1 or T2 weighted images when in the marrow edema. This is a very interesting pathway there. Ankle and foot impingements, anterior and posterior sprains. So impingements can be again maybe may lead to impingements from repetitive ankle sprain injuries, like again more movement, more mobility, laxity can lead to the impingements, lack of stability. Um Foot, you can always, like again ankle inversion, you can always all rule out the fracture of the fibula or in the foot base of the fifth metatarsal. It's not the head. You will come across heel pains, plantar fasciitis. A classical diagnosis is done. Again, you have to differentiate between the peripheral neural adverse tension also in cases of heel pain. Impingements, there is a huge role for FHL, flexor hallucis longus. Okay, so so
Uh,
we have one case, a fast bowler as a test player. So ankle surgeries, so impingements, bowling related. There was a complete lateral ligament rupture, also freaky. It was a freaky accident on the wobble board. So, but in 1.5 years, we worked for 1.5 years with him. So, made an international comeback after a gap of 4 years from the international cricket. And he made a comeback in 2007-8 IPL, and after 2003, and he played the World Cup for India. Um, you know, it was and we won, which we won the championship. So that was a very, very satisfying case. So we had to deal with so many surgeries he has gone through, but we're very proud and happy to say that his complete rehab has been done in India, and he has made an international comeback. He is proud about himself, and he's made our country proud. Again,
Dr. Badri,
yeah,
I think we are running short of time.
yeah, I'm
Other
almost
speakers are
done.
waiting, please. Sum up.
Yeah. So again, TA rupture cases we have seen complete and partial. In two cases, we have got the surgery done. And important learning in this is opting for a conservative rehab for a partial TA also with 50% of risk for recurrence is not a good idea. So a player has to go through this. So unfortunate episode. Uh, so finally got his surgery done in Melbourne, and there is return to sport and come back and everything. So elbow, you see the osteophytes, bowling impacts that and lateral elbow pain or middle elbow pain. Wrist and hand, again maybe subluxations and dislocations, collateral ligament injuries. Wrist can influence your elbow, again in the shoulder function also. Where it is very high, incidence and prevalence also very high. So TFCC trauma, the myofascial direct hit injuries, muscle related tears, wasting, hamstring is the most common injury. So you have to look for a motor control. Uh, okay. Hamstring, you should know site type and grade. MR is not the standalone clinical decision. We have a fast bowler happening in the landing leg, and we have rehabilitated a sprinter who participated in the Olympics. The tendon strains is a different world altogether. Okay, we should know what is the compression type and elongation. Loading is the key. You look for adverse neural tensions, no root compressions, ligaments we covered. Pain is not just physical. Understand the athlete tantrums. Team physios absorb pressure. Okay. So success lies in being part of collective consciousness of the teams. And we have to be very good individually, and we should be equally good together as an interdependent professionals. So, allow questions. Uh, Please share your questions with the organizers. I may not able to take questions now because actually I'm covering finals, Vijayazare Trophy. I'm in the stadium, so please forgive me that. But I promise to come back with answers if questions are uh, shared with the organizers. Thank you.
Thank you, Dr. Badri, for the nice presentation, and I'm happy that you have covered what not. Everything you have covered. It's a really marathon. Traumas which you have been explained, and some specific case studies also. So thank you, and I think we'll come up as and when we will be free.
Yeah.
So thanks.
Thank you. Thank you for giving the opportunity.
Yeah, thank you. Now you can stop your sharing the screen, please.
Yeah. Thanks.
Thanks.
Thank you, Dr. Vikram, again.
Thank
We
you.
are happy to have with us Dr. Ashok Ahujaji, who was our head of sports medicine in NSNS Patiala, and mostly I think he has produced all the sports medicine doctors in the country. So, sir, you are welcome. Now, our next speaker is Dr. Kenzom Nagmadev, who is the sports medicine and trauma specialist uh, in and working with the Central Reserve Police. You'll be happy to know that he worked and headed the Sports Medicine and Sports Science Center of Central Reserve Police Force. Additionally, he is another sportsman and the team physician too for the hockey team, men's Rio team for the Olympics 2016, team physician to the Indian police contingent at the World Police and Fire Games at Los Angeles in 2017, first team doctor for Delhi Dynamos and Pune FC in the first ISL, medical and emergency coordinator for the stadiums in the ISL matches. So, may I request Dr. Kenzam to please take up the lead role and share his presentation. Welcome, Ahuja sir. Sir, please unmute your mic. Your mic is mute. Yeah.
Yeah, good morning.
Hi, good morning.
I think Ahuja sir has to unmute his mic.
Yeah, Ahuja sir, please mic को आप unmute कीजिए.
Yeah,
Yeah.
I'm unmuted.
Yeah.
Well, I just wanted to say that I'm really privileged and honored to be with this kind of a course. And I have been following it very closely all these days, you see, depending upon the time constraints, whatever one has. But it has been a fantastic going. And I must say that today is really going to be the key day with all the various experts whom I know them personally, whether it was Badri, and it's good that he's calling from the stadium. I think there lies the whole key of all the sport personnel that they are very much backed into the grounds, and that's what we have been looking for over there. I won't interrupt. I know we got a very long session, and my dear student, Dr. Ken, is already on the floor. Thank you very much, all of you.
Dr. Ken, please.
Okay. Good morning, everybody. And I am blessed that Ahuja sir, my sports medicine Guruji, is here. He's always been like a parent to all of us, and especially to me. So, and thank you, Dr. Vikram and sir, for inviting me, and Subir Devnath sir. Actually, I was so busy with work, I actually thought the session will start at after 1:30. And then when I rechecked my thing in the evening, so till 2 o'clock, I was doing some editing of the slides, but I'll try to present. So the thing is, I've been given the responsibility of talking on sports specific injuries, and that is football. And I was also looking at the topics that were taught. You know, this conference is really good, and I think we're seeing coaches and physios and doctors and sports medicine experts. So over I think almost more than a week, the sessions have been going on. So I think Dr. Vikram gave me the responsibility of football also, because I have been a very active footballer. I mean, till my PG days also, I played club level football. So I represented the state, represented the district, represented school, was university captain. So I did play a pretty high level football, did play some international football also. So as a player also, I can understand most of the issues that are there. So although my presentation I've made, then I was looking at all the topics that were taught. So I felt that most of the injuries are coinciding. So it's when I went through the presentation, when I was making the presentation. So I think I will speak more on prevention. We'll just run through the common injuries, but like, for example, concussion. Concussion was already covered. So I was looking at most of the topics were already covered. Just a second. I hope I am able to. Is my screen being shared?
No, sir.
No, sir.
No, sir.
Please share your screen. Yeah.
Just a second, sir. I don't know what is the issue here.
Just share the screen.
No. Because actually what happened was my laptop was cleaned a few days back and I reinstalled everything. But I don't know. It's showing me the option, but not getting in shared.
Open your presentation.
Morning, Ken.
Yeah, good morning.
Yeah.
Just a second. My screen, no, because it's not giving me the option. Just a second. Just a second, please. It's just not giving me the option. Just a second. I'm so sorry.
Ken, is your Zoom updated?
Yes, I installed it last night only. Reinstalled.
So you can't see the green signal there in the share screen?
No, it came share screen. I pressed it and then everything disappeared.
You got to restart. You got to restart the Zoom, please.
Okay, just give me a second.
By the time Dr. Ken is preparing himself, I think we are having another 4 speakers, 5 speakers. So the next speaker will be Dr. Shibu Varghese. Then next will be nutritionist Dr. Aradhana Sharma. Then followed by Dr. Akshat Pandey and Dr. Vaibhav Daga. So we have almost 5 speakers as of now.
So, Kane, if you want more time, we can take Shibu.
I think you go ahead. I don't know why it's not. I'm on the speaker, I'm on the voice, I'm everything, but the share option just disappeared. So let me just sort it out. I think I'll have to exit and then
Okay. Shibu, Dr. Shibu, are you here with us?
He was there. He's here. Dr. Shibu Varghese.
Yeah, I'm here, guys.
Yeah.
Hi,
So
Vikram.
are you ready with your presentation?
Yeah, we can go. Is Ken ready? Oh, he's busy. He's stuck.
He's stuck with something. Yeah,
Take your time, buddy. Take your time, buddy.
So
yeah,
you keep cover till I
No
solve
issues, no
all the
issues.
technical issue.
Yeah.
Okay.
So I think it's better that without spending the time, without spoiling the precious time of everyone. So may I request Dr. Shibu Varghese, who will be speaking on the sports injuries in badminton. So his screen is almost on. So Dr. Shibu Varghese is an Indian and South African educated and trained specialist in orthopedic, arthroplasty, and arthroscopic surgeon with fellow training in orthopedic sports medicine. He has extensive experience in the field of orthopedic surgery, sports medicine, and with teaching. So he has worked with the international sports teams like Kerala Blasters Football Club as a team physician in 2016, ISL and Cap Cobras cricket team South Africa throughout 2013-2014. He also worked with the Asian Football Confederation medical team and anti-doping officer. At past, he has worked with the FIFA, English Cricket Country, and the Indian Cricket as an anti-doping officer. Dr. Shibu was served as a National Games anti-doping manager and member of the medical committee. He presently associated with the Meadow Hospital, Abu Dhabi as orthopedic sports surgeon. Also serves as the chief medical officer of Abu Dhabi.
यार नीचे से लग गया ऐसा लग रहा है अरे यार हाँ उधर लग हाँ बस ठीक है
Hello. Hello.
Dr. Shibu Varghese.
Yes.
Subir, he's already ready now, I think.
Can you see me, sir?
I can see you, Shibu. I can hear you also. I think we can start,
Yeah, if everybody is ready, we will go for it.
No, everybody is there inside, I think.
Okay. Okay, morning, guys. I am Shibu Verghese, and it's a pleasure to be with you for this course. I know, as discussed, we have seen the topics being overlapped and run through, but we will just familiarize us about badminton medicine, the little bit of injuries, and how we're going to tackle, so we can share our knowledge and help each other over this few time I have got with you. So to start with, badminton is a sport which originated in England, Gloucestershire, in the 1860s. It is basically started as an individual non-contact sport, which is very important to know for us, which requires a lot of combination of jump, lunges, quick changes in the direction, and the rapid movements. It's one of the fastest racket sport in the world. That was reaching up to 200 mph in an international event. So when the high level at which it is played and the fastness of the powerfulness of the game, we know the level of strength, agility, endurance, and the tactical awareness required in the sport. So
please
the
unmute others.
sport
Please
presents as a good example of the impairment and the dysfunction which is within the kinetic chain and the links along with the same kinetic pathway. So we need to know how to see normal badminton court. Somebody's.
please mute others, please.
Please mute your mic. Some participants, आप बात कर रहे हैं. Please mute your mic. पार्टिसिपेंट से अनुरोध है कि कृपया आप अपना माइक को म्यूट करें. फिर भी कृपेश जी, मिस्टर कृपेश, प्लीज म्यूट योर माइक. मौसमी हीरा, प्लीज म्यूट योर माइक.
सर आई थिंक उनसे गलती से हो गया है, तो होस्ट प्लीज वो कर दें उनको म्यूट.
अनु जोशी जी, प्लीज म्यूट योर माइक.
सर आई एम सजेस्टिंग समथिंग, दैट्स इट.
Don't suggest in between. Let the speaker to take over the mic. Let us to listen him only. That's all. Please, Dr. Shivu.
If you can mute all the mics. Okay, so the badminton court measures around 6.7 meters in length and 5.18 in singles, and then it's 6.1 in the width in doubles. So the speed and agility and the movement of the players ensure that the position of to accept and play each and every shot. The consequence of not doing so has an adverse mechanical strain on the joints, soft tissues, and it affects the performance as well as injuries. So it's a highly physiologically demanding sport, and an average rally can last up to sometimes around 5 seconds, followed by an average recovery of 5 to 10 seconds. And in a high level match, it can last up to an hour. So that's the amount of intensity at which the sport is played. So it has been demonstrated in studies that and training and competition, the level of the high players are up to 80% of maximum of their heart rate at 85% of the time. So you can know that during a badminton match, it's the level of intensity at which it is played. A well-developed aerobic endurance capacity seems to be necessary for the fast recovery between the rallies or an intensive training workout. So to demand and to these such highly demand, the strength, the plyometrics, the speed and the stability of an athlete plays a very important role. So coming into badminton medicine. So what is badminton medicine? Badminton medicine is a multidisciplinary approach to the healthcare where you treat those who are severely involved in the sport. Healthcare professionals from many disciplines are involved in the care of the athlete. So when you come into the basic system of the badminton medicine, as we always have been studying in sports medicine, it's the athlete who pivotal role, followed by the coach, the trainer. Then you have the medical aspect with the physician and the physiotherapist. Then you have additional sports physiotherapist for the massage therapist. Then you have added now with the nutrition or the dietitian. Developing with international sport, you think about having more involvement with the psychological aspect with the psychologist, and then other parts of this. So it's a cogwheel chain where everybody has to work together to develop the athlete and help him at different modes. For every athlete, it's important that he undergoes a pre-participation or a physical examination. To all my athletes who come to me, it's an integral part of competitive sport. So what is the importance of doing the PPE or the pre-participation physical examination? It's to identify the athlete who are at risk for a specific injury. And then we start or identify them. Once we identify them, we help them to prevent it by avoiding the techniques so that there is avoiding an injury in the season. So what are the main goals? We need to identify the athlete's general health. We need to determine whether the physical limits to participate. We need to identify the condition that may put the athlete at risk for an injury. And we also need to determine the individual qualifications of the athlete, because no two athletes are the same physically and mentally. In our world of sport, as you come down into the Middle East, there's a lot of things coming with, and you will start seeing that soon in India, that is the fulfilling the insurance and legal requirements. And it's there as your sports get more of approval and there is a lot of international or a professionalism coming in. Insurance have to be fulfilled, and there's a lot of legal requirements where we need to transfer. You've seen players or athletes getting transferred from one club to another club. There is a lot of pre-participation examination screening being done. If it's an under-level athlete or an underage athlete, you need to determine the level and the maturity level of the athlete. You need to plan for the areas of improvement prior to participation. There are sometimes you need to understand badminton, para-badminton is a big sport. So we need to identify the students with special health issues. We need to provide them a personal education on the personal health issues. Secondly, the pre-participation screening also helps you to develop or maintain a patient-doctor relationship. And this can be a vital or breaking the ice before your season starts in. Determinants of clearance. Another important thing is the athlete at the risk of increased risk of injury because of a pre-existing condition or injury. Will the pre-existing condition place another competitor at risk when you're playing doubles and other things like that? Will the treatment allow the athlete to participate safely? Can the play be limited while the athlete is undergoing treatment? So these are all important for the determination of screening, and return to play has to be decided on these modalities. As you know that we are traveling now with COVID coming in, immunization status, vaccination would play another important role. If it's a female athlete, you need to have proper menstrual history. You need to have a proper status of the pulmonary status, which you will have the respiratory medicine or the general medicine doctor do it. You can check the neurological status of the player, musculoskeletal done by the sports physician or the physiotherapist. And then you can do the identification of the recent or illnesses or injuries. The components of the pre-participation examination is we need to identify also the medical conditions required. We need to find out whether they have any other issues, like for example, if they have an asthma, they're taking an inhaler, we need to take therapeutic use exemption for the anti-doping. These all help us in the pre-participation examination, which is being followed. If they have undergone any prior surgical history, if they have undergone any prior hospitalization, use of medication. So an athlete, when he travels for in the tournament, does he need to carry any medications for use? Identification of the allergies, food, and even medicinal allergies need to be noted in these conditions and in these participation examinations. Finally, we need to know the factors that are related to the injuries. There are intrinsic factors and there are extrinsic factors. The intrinsic factors are basically we got somebody else coming in. Okay, the intrinsic factors basically are you looking at the thoracolumbar stiffness, tightness of the lower limb muscles, the muscle imbalances which we need to be identified. Proper conditioning is required for the aerobic fitness, speed, and agility work. We should have a more movement economy. Power and agility is very important to prevent or can largely influence injury. So we need to address all this. For example, if you are doing if there's a poor push-up forward on a non-racket leg, that means the player tries to reach the shuttle late and must lunge deeply to reach it. It can place additional strain on the patellar tendon, hip flexors, and the spine. So we need to have a proper muscle balancing in all the athletes, and these all can lead to injuries. So this has to be identified prior, and we have to condition the athlete prior to the start of the season. For example, if they push off backwards, which means the shuttle is more likely to hit behind the player. So there's an adverse strain on the thoracolumbar spine. So this has to be understood by the doctor or the physiotherapist, and more important, should be given to the core strengthening so that the injury prevention can be done, and good abdominal work should be done prior to the season. And we have to load the athlete properly so that there is no injury during the season. So all these are important intrinsic factors which can cause problems to the athlete and help us to prevent the injuries. Surfaces we play on are the extrinsic factors. Basically, we know the pattern and codes are ideally consist of spring floors, which are optimal with thin covering surfaces for the shoe surface friction. There are studies to show that the friction which is increased can cause a lot of injuries. We need to know that we start training for the badminton and other sport at very young age. So the intensity starts increasing. So we need to train the athlete or create a habit so that the athlete does not get injured. So the likelihood of lower limb injuries are quite high if there is a lack of the traction. So we need to be careful of the surfaces to be used also. Rackets, very important. We need to know how an athlete chooses his racket, even though we don't have much involvement in it. But as sports science develops, we know that the modern racket is around 100 grams. Heavier racket will put a lot of load on the wrist because of the mobility of the wrist and the requirement for the shots to be played. So the difference between the heavy and the light is around 15 to 20 grams, but that too can play a different role in related to the injury as it becomes more and more chronic use. There are different types of grips used in different countries. Japan, it's like G2 to G5 folk size grips. And then in some countries, they use a small, medium, and large. Basically, the attacking players would love larger grips so that they can hold on to the racket more tightly to generate more power. So a smaller grip means the racket is easy to move for the rallying. So we need to understand this. You need to understand a little bit more about sport when you get involved with the athletes, because that's how we can identify. We should be a good observer on the side of the court to know how the athletes pick up these injuries, and it will help us to understand and fight these injuries. So we need to know about these strings, how they are made, or what are the strings used, the natural gut ones, or you are using the synthetic type ones now. The gut ones provide a feel and a control. They vibrate less, but they are less durable because it wears off fast and are more expensive. Then there are different numbers for the strings. The thicker strings are more durable and give more control, but not much power. The thinner things have a greater power and they last longer. So you need to know when your athlete brings up these issues. So you need to have a proper idea of their equipment, what are the things they use, everything. You need to have an idea as a sports physician or a sports therapist. See, the most common thing what we face as a doctor is the training errors. When things are all good, everything is fine. The athlete is performing well, doing well. The problem is when they come up with an injury. That's when we need to understand and go back to the drawing board why this injury has occurred. And then our plan or our target or our main issue is how can we prevent this injury from occurring again, or how can we help the athlete to come over this, because these injuries can cause a lot of psychological effect on the athlete too. So you need to know that these bodies are high demanding bodies where you need to lunge, rotate, jump. You can have repetitive impact. So you need to have proper cardiovascular conditioning and the agility and the footwork. So you need to know that how the positioning of the athlete is there. You could do some things like there are during trainings, you could have video recordings of the trainings, how they move about, sit with your trainers and decide about the movements of the hips, sit with your physiotherapist and the strength conditioning coach and analyze it and corrected. Coming to injuries, I'm just keeping it as simple as possible so that we can understand any common classification. You could have acute, acute and chronic, and the chronic overload. Okay, so for me, the toughest sort of injuries are the chronic overload injuries. Acute are a little more easier to manage if you are smart enough to handle it properly. The chronic ones and the acute and chronic injuries are the ones which we need to really put our work on, because we know that there has been a chance for these athletes, because when you do your pre-participation examination and other examinations, you know that these athletes will be having this, and that's where we need to give more importance to. Coming to the acute injuries, you could have an acute tender Achilles injury. So that is the Achilles could be torn at the insertion, it could be torn mid-substance. So these are very, very common. So how do you do it? You need to do an ultrasound to find out whether the Achilles tendon is torn. We can do an MRI to support it. I would prefer an ultrasound prior at the site of if you have available for an ultrasound there. Otherwise, you can do for an MRI scan to find the Achilles tendon injury, depending upon the tear. If it's a complete tear, we would love to do, or we would be forced to do Achilles tendon repair. There are new techniques to do the Achilles tendon repair with percutaneous methods, or you could go for an open repair. You know that once an athlete is in an Achilles tendon post-surgery, he is off for at least 3 to 6 months. He's off training and he's off injury. He needs to recover. So the rehabilitation part comes in. Then you need to really know what is the cause of the injury. Is there any other thing that we are missing? Another common acute injury which is occurring in the ankle is the ankle sprain. You can find, which is commonly discussed already, is the ligaments which are involved. You need to strengthen this. So you need to prevent, you need to rehabilitate your ankle. You need to identify if the athlete is prone to an ankle injury. You know the different types of ankle sprains. I'm not going into this. Secondly, you have, or thirdly, you have is the knee injuries. Knee injuries are multi-ligament injuries. You could have an ACL, that is the ligament in the front could be torn. The ligament in the back could be torn, that's the PCL. And the ligament in the inner half is called the medial collateral ligament. And the ligament in the outer half is called the lateral collateral ligament. So all these can be torn, and these all can get affected also. So you need to understand what level of the tear it is. If it is completely torn, then the athlete will have to undergo reconstruction. Along with these, the other injuries which are very common in acute are the meniscal injuries. Meniscal injuries are the two meniscus, the lateral and the medial meniscus, which come in between the tibia, that is the lower leg bone, and the thigh bone or the femur. There are different types of tears in it, and you need to repair these tears. I would primarily go for a meniscal repair in all my primary conditions, because we need to preserve the natural meniscus as much as possible. Coming to the other tears or common tears you could have, or an acute injury, would be the rotator cuff injury or a Bankart, that is the labral tear. These are the two common acute injuries which would occur. Rotator cuff tears in badminton, I would think it's more chronic injuries, but acute injuries comparatively very low. But if there is an acute injury, the primary one would be rehab. And depending on the tear, we would think about doing an arthroscopic assisted rotator cuff repair. Then next coming to is the muscle strain. There are different types of gradings for the muscle strain. The common muscles could be involved are the hamstrings, the quadricep muscles. So these are the common acute injuries which could happen. But muscle strains are also involved in the part of acute and chronic injuries. Coming to the chronic overload injuries, these basically affect the tendons. You know, the tendons, basically they affect the tendons and the spine basically. So common are the patellar tendons and the Achilles tendons. So commonly you can see, as in the X-ray, there could be an enthesiopathy. So we can see that where the Achilles or the patellar tendon inserts in the knee as well as the ankle respectively, you could have the bony growth there, which would weaken the tendon. You have seen athletes being injected with steroids, and these can give off suddenly due to the repetitive loading, jumping, and high impact. These sort of injuries are common in amateur or recreational athletes who are above 40 plus, because there's a lot of chronic overload to keep on playing for longer period, and then this could occur. Coming to the patellar tendinopathy, they could have you need to know that lunging is the main cause of it. You need to assess it properly. You need to have the athlete to take off the sport, go into rehab, strengthen your tendon, reduce the inflammation around the tendon, get it to activate, and then return into sport. So you should just not avoid it, because you can know that patellar tendinopathy can progress, and finally the patellar tendon can rupture too. There's a lot of studies in which the tendinopathy could be treated much better. Now, instead of steroids, we're using something called the PRP, the platelet-rich plasma, which is injected into it. It is accepted by the IOC, and it's not coming under, so it's free from anti-doping. So you are allowed to use, you don't need a therapeutic use exemption. We need to understand that the Achilles tendinitis can result in for later going to tendinopathy. So you need to do the biomechanical factors. You need to understand the strengthening, the flexibility. You should also know how the knee position is, whether is there anything else in the valgus, does the knee have position is in valgus or the varus. Also, as we said, the factors to know is the surface area where the player trains on. So we need to go back retrospectively and find out the cause if we have missed it or not done it primarily in our pre-participation examination. Shoulder injuries, chronic, I would go for the subacromial impingement. Repeated chronic tear where your acromion starts rubbing on your rotator cuff muscles, tendon, the rotator cuff tendon. There could be early arthritis. I've seen a lot of athletes who are younger but could have arthritic changes in the acromion process, which could cause the subacromial impingement and also result in this and a subacromial bursitis. So the space between the acromion and the rotator cuff tendon is reduced. As a result, whenever the arc is elevated,
इंतजाम कर दीजिए और वो सर्विंग वाले भी रख दीजिएगा जो सर्व वगैरह करे.
So
चाय मतलब ये पानी पहले स्टार्टिंग में चाय.
So as the arc is elevated, the athlete would have a lot of feel of sudden shooting pain in the shoulder, unable to elevate the arm. You have the pain, the arc syndrome coming in. So these are identified immediately. So we need to do conditioning programs to strengthen the rotator cuff. I feel all this has to be done because the common things for the athlete would be to work on the shoulder and the ankle and the knees. So you need to do a rehab proper before you get the athlete back on. Among the chronic injuries, too much of overloading, as you said, when you go for the backward push, the spine is once impacted. Sometimes there is a chance for disc degeneration and ossified.
Participants, please keep your mic mute.
So spondylosis is a very it's not common, but it could be there in a chronic injuries. Player fail to getting the shuttle back, have to retrieve back, resulting lack of power. So core strengthening, core stability programs have to be given at most. Coming to wrist injuries, very common because of the flexibility of the athlete. In badminton, common is you could have a decurrence tenosynovitis, very common. You could see that the tena's snuff box is highly inflamed. You could have the tendons. You could do a couple of PRP injections to elevate it. If still doesn't improve, then you go into the de-roofing of the first compartment. Along with, you could have the tendons inflamed along with this. This is where you need to give the attention to the grip of the racket, the weights, how the athlete uses the different movements coming in. So we need to pay a good attention to avoid wrist injuries. Another one we need to come to understand is the elbow injuries. I think this has been covered previously also. Common injuries are the golfers or the tennis elbow. Common ones, you need to know that the tennis elbow is because it's on the outer half or the lateral aspect. It's the extensor group of muscles which cause it. Golfers is the medial one and the flexor group of muscles. How do I tackle it? Very simple. You need to give it rest, icing. You can give a tennis elbow support, keep the player off, rehab it, strengthen the elbow, get in back. If he still has or she has the chronic injuries and things, we can go in for injections. I would avoid a steroid injection. I would go with PRP. And if the PRP doesn't come through, and if his athlete is still suffering for a long time, then we go for the release, arthroscopic assisted, or you can go for an open release of the associated fibers. Some things I would like to add coming into the sports science involvement into is we need always to keep our athlete at top notch. See, even though it's a very, very competitive sport, athletes among you can find that even when you play, you want to play at your top performance. So you need to know everything at it. You have variables like the GPS tracking to help us to know the strains and stress the athletes have, which is the time, or which is how does he peak and things like that. Then you have the strapped cord working muscle to know the oxygenation level of your body, of the blood in the skin, and it is an optimal sensor, the Humon, which could be used. You can know how your foot strike by the Sensorious socks. See the weight distribution. You need to see the rhythm movements, which is very important in badminton, to know how your balancing is. So there's a lot of developments in the sports science arena, which we can use to help us. So we have to be having an open mind to understand which is good and use it for the best for an athlete. As a wrap, the final thing I would talk is the BATAC Lite, because badminton, like Formula One, is a very important hand-to-eye coordination system. So this can be implemented or fit into your walls, and these are strong, highly polished stainless steel ones, and then the lights pop up, and then you have to press on it. It can be easily put in your car as a medium hatchback car. Anyway, you can use it and take it to your venues. So this is just the basic broad outline I have given about the different injuries of badminton. I've tried to keep it simple because many of these injuries are very, very common. So as I wrap, my primary importance as a sports physician or an orthopedic sports surgeon, or talking to you with sports interest in sports physiotherapy, is we need to do a proper pre-participation examination of all athletes. We need to do a proper documentation of it. We need to do a proper head-to-toe examination, take out every detail. Your athletes, every record should be with you. Depending on that, it helps us. It helps us as we start collecting information. We can find out that we can prevent injuries, and injuries do happen. And once injuries happen, it's us to identify the injuries, how to tackle the injuries, how to keep the decision to keep them off play, how to rehab them, how to decide when we will put them or return to play. We have to be very, very judicious in doing this. And the most important thing as a sports physician is always being to be the part of a team player. Okay, thank you guys for giving me this opportunity to talk, and I'm ready for any questions if you would love to ask me.
So thanks a lot, Shibu, and we are open for the questions. So guys, feel free to ask. And Shibu, in the meantime, what is the importance of sports gear? If we talk about like tennis elbow, so apart from strength and conditioning, would you like to recommend anything related to sports gear? So like the racket, what kind of racket, or the grip or something like that?
See, it depends on what, this is where we have to be specific. It's like I am different from another person. So it has to be the player's choice. It's about how the player decides to choose what sort of game he would love to play. So you would love a lighter racket for somebody who doesn't have a power or an aggressive play. The stronger ones would be want to having aggressive power. So it is how he and his coach decides. But the variation comes, that's where we as sports physicians come into play. When we do the screening, we have to see that if we want to have a heavier racket, we have to make sure the strength and conditioning coach works on his wrist to get it much stronger. So we can change, you can change, like the example is simple, is how if he's having a wrist injury, we would not want him to play with a heavier racket. So what would we do? We would like to change it. Then we'll have to modulate or change his game a little bit. So it's a thin, fine line, but it's a teamwork. That's where we need to, all of us need to sit around the table and decide how can we do it. It's not, there's no one simple goal, but it's all of us together. That's the way I would like to put it, Vikram.
Okay, great. So Mohammad Amjad Khan, you have a question. So please unmute yourself and ask.
Yes, sir. Sir Shibu Varghese, it was very informative and it has definitely increased my knowledge and I will put it in my skills, inshallah. Sir, my question is, while we are discussing about ankle injuries, we are much paying effort on strengthening the ankle muscles and we are not paying emphasis on proprioceptive rehabilitation and balance. Though we know that the main function of the foot is balance and proprioception, and it is a much importance in athletes especially. So what do you like to highlight on it, sir, something, please?
See, this is where, this is where you understand basically when we work, I see right now I work with Al Jazeera Football Club. I am an orthopedic surgeon, but I work with club. I manage the under 21 players.
Very
So
nice.
as a surgeon, I'm telling you, as Vikram would know, that as orthopedic surgeons, we were taught that let's do the surgery and finish it, and then we will do the rehab, we will do the things, and then the sport has developed, and we have got ample support from our physiotherapists who know how to function it. It is not just doing the surgery. Rehab plays a very important role. As you said, we need to work on the proprioception. Proprioception is the primary goal.
Yes,
If you
sir.
don't get proprioception and you don't correct what is the cause of injury, this re-injury will occur. You will be sitting 1 year down the table and you will be finding that the injury has occurred, and you know who is to blame? Us
Yes, sir.
and our physiotherapy team. It's us. You have to promote proprioception. Like for your ankle, you have your disc to balance and see how your proprioception. For your knee ACL surgery, proprioception. How, the first thing an athlete comes when you have a ACL injury, that he says that I have a feeling of giving way. It's that feeling of giving way. It is that proprioception has to come. He should have the feeling that his ACL is strong back. His ankle injuries, his ankle ligaments are all strength. I have come back. Unless he gets that confidence back in, unless the proprioception and the balancing, you should check your. See, always, for example, like when you have an injury in the ankle, you should start going from the core to the hip and seeing again and again. Have you missed something? Rework yourself, go back to your participation screening and keep on examining each and every system again where you have missed it. You can find something which you have missed, and I promise you correct that, it will help the athlete. You can find that sometimes you could have a flat feet, you miss flat feet. You've made that it could be a pronate. These are small things which you find suddenly. You have amateur athletes who run and come to you with shin pain. They go to multiple doctors and physiotherapists, and then suddenly you find that my sports physio found that I have a flat feet, doctor, what to do? Then you need to do the foot gait. You have to see the foot mapping, see the weight transfer. Then you can correct the shoes. And you see, as the athlete puts a insole, it helps his medial tibial stress syndrome. And then after 6 months to 3 months, he comes back with again, I'm putting the insole, but doctor is still coming. Then you take the insole out and the physio finds out it's worn off. See, this is a continued process. This is it's not a one-stop gap arrangement. We have to work as a team, and we have to work continuously. We have to see everything, how you wear your shoes, the number of sock you wear. Some athletes love to wear double sock. See how the sizing of the shoe, how everything you have to take it is a proper, it's like how you take care of a baby. You have to put it that way. Your athlete is like your baby. I hope Amjad, I've been clear to you.
Yeah, sir, very, very much, sir. Very much. Sir, one more question I would like to ask, if the time permits you. Sir, if you remember, in 2004, Shane Bond has suffered spinal stress fracture. So what are the precautions or measures should be taken by fast bowlers to prevent this type of stress fractures, and which has scrambled him and ruined his career? I feel it.
You are talking about Shane
Bond in 2004,
the New Zealand fast bowler.
Yeah.
Okay. I think there was a speaker before us who spoke really well on that.
But I could not get a chance to ask him this question.
But I think he spoke really well on that. See, basically, it's how you build you need to strengthen your core. There are multiple factors in it. You should see what is what was his bowling action? What was his technique? Was he a front on, side on bowler? It is all, we have to see everything individually. You have to go back into the drawing board. If you ask me, what is the only thing that can help Shibu Verghese? You cannot find that. You have to individually screen him. What is his foot? How does he land his foot? How is his bowling action? Now you can see Bumrah. Bumrah is an ideal candidate for having more, I'm sorry to use a name, he's an ideal candidate to have a lot of stress fractures in chronic time if you don't use properly. It depends on the workload you give him, how many number of bowls you bowl. The problem is we only see the number of bowls is bowled in the match. No, it should be in the training. Every ball he bowls should be noted. So this is where you need, there is the ECB, I think the Australian Cricket Board and the English Cricket Board have workload guidelines from under 13. How many number of bowls they should bowl in a week, how much in a training session. That is why you have seen recently also in the England Test series, Jitin Patel, the spinner coach, would not allow Jack Leach to bowl the complete delivery. He used to bowl only half pitch deliveries so that the number of stress would be, but just to get his landing proper, the flight proper, they used to just get him that. So see, it depends. Every ball value. See, this is like it's a very every athlete or every ball that a bowler bowls is very precious now. Everything is it's money. So every ball has to have his value. So every ball he trains also has to have value. You can't stop training. So I feel it is individualized. It's a specialized thing that you have to manage the workload. So workload is very important. Technique of the bowler is very important. Screening is important. Strengthening is very important. And core, everybody misses the thing is core is very important for us to strengthen.
Okay, thanks a lot, Shibu. So I think now we can, Subirji, shall we move ahead? The next speaker.
Vikram, one word. Thank you guys. It's been a privilege, Vikram. Thank you for having me on board. I wish you all the best. If you need to ask me any questions, Vikram will share you my mobile number and email.
Yeah.
Enjoy the course, have fun, and I enjoyed this 20 minutes. And Ken, we need to meet up soon, buddy.
Shibu, that was not my response.
And Shibu and Ken, I still remember those days at Mumbai. Yeah.
Oh, the BCCI course. Right.
Yeah.
I know I'm back and I'm just going to try to share my screen. Will the administrator permit me to share the screen?
Yeah, this is allowed. Please.
You are screen sharing. Okay. So let's see. I hope. Am I on?
Yes.
Yeah. Thank God. Okay. So first and foremost, I think Dr. Shibu also managed to cover a lot of the things, so it'll reduce my burden. And the previous speaker before me, and I was checking all the when I was talking, I was checking at all the speakers. They've kind of covered almost everything. So what I'd like to do is, I think the introduction has already been done. So I've been given the beautiful opportunity to speak on football and football injuries. I will focus more on prevention because, and the things that basically that, which has already been covered as managing all the different injuries, managing all the different, the rehab, that has all been covered. So I'll try and cover more space, which generally we miss out, or we are not, the people who are, not being exposed to football as such. So we will discuss that, which would actually help more of the administrative factor, because we also, as doctors and the sports sciences, physiotherapists, we see that it's generally the issues with coaches and with players and with management that we were not able to, mitigate the injuries. So before I start, thank you once again, Dr. Vikram. And of course, with the blessings of my Guruji, Dr. Ashok Ahuja, I would like to start. So like we say, football is the beautiful game. Football is, we know, the most widely played sport in the world. That's why obviously the injuries are going to be more. Injuries in football are unfortunately exceedingly common. And they occur more frequently in younger players, with 80% of injuries occurring in players under the age of 24 and 44% of injuries occurring in players under the age of 15. By the way, whatever I'm quoting is everything from FIFA and AFC. All the data is research-based, has been given by FIFA and AFC, nothing from my own side. Injury rates in female players tend to be higher for ACL injuries and concussions, which Dr. Sonika must have spoken about, and there were a few other, all the other sports, they talk about this. And of course, we know because of the unique anatomy, Q angle, the running technique of the female athletes. Injuries can have a significant, physical, emotional, psychosocial, and financial impact on both the individual and the team. This is one thing we as doctors and the support staff need to understand, because when we are not involved with the so I'll just give an example with if you talk about my local CRPF team and all. So he's been recruited especially for football, and he has played football all his life. He doesn't know what to do much, and suddenly once he gets injured, he's out of the team. When he's out of the team, obviously here's a person who's been flying on the ground, who's been the best footballer. He's, every time he scores a goal, the team is lifting him up, and it does tremendously boost his confidence and his quality of life. And if he's in a club level, he's picked up by bigger clubs. But once he gets injured, here's a guy who's flying, he's not even able to walk. And then unfortunately, what happens most of the time, the only people who see him are doctors and physios. And as doctors also, we just see him maybe once in a week for review. It's the physiotherapists and the trainers who are mostly with them. So I think it's very important to understand that aspect and give them more support, especially when they're trying to return back to fitness and sports. So that's why I feel that prevention would be more important than treating. As we grow, we see that prevention will really, really help. And of course, like over the past 2 decades, football is one of the few, FIFA is one of the few institutes, a sports federation who has been doing tremendous work through the FMARC and through various medical studies and medical support. Like just a simple thing that they've made AED mandatory. They've made, like, for all the even ISL matches and all, they've made ambulances mandatory. They have made support staff mandatory. They've made first aiders mandatory. They've made a doctor on the pitch mandatory. They've made a doctor with the team mandatory, a physiotherapist mandatory. So I think, I hope that the other sports federations will also follow suit. And of course, they have the FIFA 11+ injury prevention program, which has been developed. And now they have a specific version for kids and children, because children are the ones who are getting the most injured. And referees too. We tend to, when we look football, we look only at players. But a lot of referees get injured. Do you know the amount of running that a referee has to do? So I think the referee has to really be extremely fit. So they've developed the 11+ for the referee also. So my talk here would be more that everyone who's seeing this, I mean, most of my doctor colleagues, they know we're in it. We're already in the program. But I suggest all of you who are listening to us today, you should just take one big home message. If you're talking about sports injuries, my message would be just go to the FIFA website, or for that matter, if you're in any other sport like badminton or everything, every international federation has a website like FINA or FIGO or any of those FIFA. They all have these websites where they have a beautiful way of managing the injuries, preventing the injuries, and they have a lot of scientific discussions on that too. So this will really help as a source also for you to go back. And if you're especially treating a player like Dr. Shibu covered badminton very beautifully right now. He spoke about a technique, about the strings, about the gut. He spoke about individualization, which is there same in football. So actually he's made my work a little bit easier. So what happens as doctors and physios for us mainly is that we need to convince the coaches mainly, to implement injury prevention practices. So for that, it's always good when the federation supports and helps you for that. And we have to make them understand that actually that this will actually help them perform in their team. Because if they have a player they bought who's expensive, they've like say IPL now, a player has been sold for 5 crores, 10 crores, football is higher. And then suddenly you find the player is injured and the season is off. You're losing money also, you're losing a good player also, and the team is definitely not going to perform as good. So we know why football is again one of the biggest sources of injury, sometimes the biggest sources of income to a lot of doctors and physios. Football is also high contact. It's a high energy sport. And of course, the repetitive nature and high impact sport can leave players sidelined with a variety of different football injuries. And if you just heard Dr. Shibu just now, he talked about load management. So here, the load management is also very important. Now, because sports has become very lucrative, you know, a lot of players play extra matches. So without taking care of the recovery. And if you all has been watching ISL the last few years, a lot of players come from European countries where it's cold. Then they come to India. They play in Chennai. They play in Goa. They play in Guwahati, where it's extremely humid. And then the workload, like you're playing one match, then instead of recovery, you're actually traveling on a flight. You reach the next day, you just have a small practice session, and next day you're again playing. So we see injuries left, right, and center mainly because of load management, which again, Dr. Shibu has also covered before this. So like I said, again, football injuries, because being one of the most popular sports with most of the people playing, that's why we also get more number of injuries. And we know we have, you have players, you see, who's very strong, who's very fit, and then they're jumping in the air together, they're colliding, we have high contact, there's tackling. So that's why injuries are going to happen. Of course, some of the examples would be like, you know, sprains and strains, fractures, tears, muscle tears, concussion. Concussion has been covered by Dr. Nishit, so I'm not going to go too much into discussion into that. Spinal injuries, again, generally has been covered just now by the cricketer. The spinal injuries generally in football has always been contact. Generally, if you all notice that infamous Neymar was kicked in the back and where he had a pars interarticularis fracture, that's also very common. Heat injuries, what was I was talking about when you tend to play, we tend to neglect it. But this is the medical part where you have heat injuries. The individual starts only talking about a little bit of fatigue. It starts with fatigue. And then we need to also look at heat injuries. Heat injuries, the commonest, the best thing for heat injuries is pacing the load, ensuring you're properly hydrated, good sleep, good rest, good recovery, and no alcohol. And overuse injuries, of course, one of the commonest if you're going to just try and classify that. So again, why do we have so many footballing injuries in professional? Because the demands of professional players are clearly higher than the amateur and recreational footballer. For example, right now, what happens is, like, I have a team who's playing local league. So they've also qualified for the national league. And then they have another invitational tournament. So ideally, if you look at it, you need to play maybe maximum 2 matches, but you end up playing 3 to sometimes 4 matches in a week with no time for recovery, and there's so much of travel. So this is where, in my personal experience too, I've been facing a lot of injuries. So that is the reason why with my team, what we've done is we've increased the base of the team, as in instead of usually sticking to only 24, 25, now we have 40 people in the team. And then the top level players play in the top matches where it's really, really important. And then we rest these players on the matches which are like invitational or which are thing, or we just put in the player for some time and then we take them off, especially if the player is a star and, you know, the public has come to see the star. So we just let that player play after 15, 20 minutes and we tell them it's invitational, don't go all out and don't try to get injured or don't try to get tackled. And because, like I said, again, increasing physical demands and injury prevention programs are performed very poorly. Dr. Shibu discussed about the injury prevention program right now, and football has the FIFA 11. It's already been distributed to everyone. Unfortunately, most of the coaches and actually they are the ones who implement the training program. So they don't really follow it. So compliance factor, because in India, especially, what I feel is most of our coaches are really not highly educated. They don't like to read too much. So most of them have been good players and just gone on to become coaches. So at least those people who do a PG diploma, NIS or something like that, at least they're educated. And when they meet a physio or a doctor who explains, a team doctor explains to them, they feel that doctors and physios, our role would be mainly when they get an injury, then our role starts, or if there's an emergency. So they don't like to be interfered with. But I think what we can do is we can try and educate them also. And, you know, nowadays we have a group, say a football group, if you're going for a match, so you can share the FIFA 11 plus in the group. You could kind of talk to the coach, get friendly, get them on your side. So that way you will actually reduce the number of injuries and you will reduce your workload and improve the performance. Because ultimately it boils down to performance. If you're injured, your performance is going to go down. It's just a small repeat. I missed out on the minor bruises, cuts, contusion, black toes, etc., which we don't realize, which happens in football. You're sliding, you have a tackle, you just hit someone, and then you have a small little bruise and cut, and the players actually don't take care of it immediately. So I think the immediate emergency part, we should take care of that also. It's very important. It prevents infection. And then later on, when the bruises or the cuts are a little bit bigger, and we just tend to neglect it because, you know, the pain threshold of the international or top level athletes is very high. They don't feel the pain, they just clean it. They don't even use antibiotics properly. They don't comply with your treatment if you don't force it on them. And then they come back with more severe injuries, which actually takes off from the playing. So here, if it was taken care of, the player could have continued after 2-3 days. But then now he's got cellulitis, he's got abscess, and then he or she, and then we end up losing the player for 2 weeks. And then you also lose training time, especially if it's in crucial areas of the joint or the bigger muscles, you know, where you really require to work. In football, say the lower limbs. Commonest we see are ankle sprains, knee injuries, ACL. Hamstring is the commonest, and the next, rather than the quads. Quads generally, which I see, is always been contact, but groin strains are definitely very, very common. Adductors, hip pointers, shoulder dislocations, acromioclavicular sprains, wrist and hand injuries because of falls and pulls, and football concussions. Kicks, heading. I am not going to go too much into discussion of concussion because it's already been taught. The principles and protocols of concussion are the same in all sports, across all sports. So here is a slide which shows, which you can easily go online, and you can see that we have the SCAT-5. I believe all support staff here who are working. You can take a printout, make a sheet, and just make a sheet of it and keep it on the ground with you. And it's always good for quick review and referral. And whenever you doubt a concussion or a head injury, please take the player out. It's more important to save the individual's life. Here we tend to say, no, he's our best player, we cannot take him out, or assess him. If you assess him quickly and you see it's a concussion, or sometimes when you're watching the sport, in the game, and when you see that there's been a good, with a good amount of speed, power and torque, that there's been a concussion or a neck injury, I suggest definitely get the player out. Saving a life is more important than winning a match, one match. If we save his life or we treat him properly, he's going to win a lot of matches for us in the future. Of course, I think the on-field management, the first aid, and again has been taught. So just remember that we have the Dr. ABC. And I again suggest here that each and every support staff, including the coaches and preferably the players too, should be taught first aid and CPR. Should definitely be taught first aid and CPR, including the players. I've been doing it with my teams. When you take your off-day sessions, you teach them, get a team from outside. If you get a team who teaches CPR, BLS, and make it interesting, work on the dummy, teach them how to do first aid, teach them how to evacuate the players. This will really help in saving lives in the long run. Most of the lives saved on the ground, whether it's my player or whether it's my a soldier, most of the time the life saves has been by these basic people who knew first aid and CPR. Because it's when they come to the hospital, then we start with all the medical treatment. But it's a crucial time that when you're evacuating the player from the ground, that is very important. Like we say, the golden hour, golden period, or golden few seconds. If you start CPR immediately, if you can handle the injuries or recognize the injuries quickly, life-threatening, definitely we can save lives and save the athletes. So the facial injuries, talking on the last day is an advantage because everything has been covered. So, however, I'm just going to talk from the top down, from the head. We spoke about concussion, head injuries, the neck injuries. Now we talk about facial injuries, where you have, you have a lot of corneal abrasions, traumatic iritis, traumatic hyphema, and orbital fractures. We don't realize it, but generally, when you have elbowing, when you're jumping up, with the FIFA rules also have changed now that they said you cannot do with the hand and the elbow up when you're going for heading the ball. But at lower levels, where at lower levels, whoever have played at slightly lower levels, we get more injuries over there, because if the referee acts smart, even the referee gets beaten up. So when we used to play football matches in college, I found out 50% of my team players go to football match with a hockey stick. Because then we don't, university matches and all that stuff, club matches, if there's a fight going to happen, they are ready for it. So unfortunate. Lower levels, because there's no sanctions, there's no punishment, you just have to win the match. There's a fight if you're losing. But at top level, what happens is, you cannot question the referee. You are going to be penalized. You're going to be fined. You're going to be red carded. You're going to be kicked out of the, say in India, if you're with the Football Federation, you're going to be kicked out from the team. So those are deterrents. So, but otherwise, we start having fights if there's been a bad decision or somebody has tackled the player and then he just gets angry and then they start fighting. Bad decision has come. They beat up the referee also. So I think the rules and regulations have to be enforced at slightly lower level also. We don't talk about these things. So like I said, all the medical and surgical injuries have already been discussed over the last few days. So I thought I should talk about these based on my personal experience too. Like we all know, once you get injured, what to do. You follow the price and police protocol, protect the eye immediately and ensure that any eye injury, kindly, and I speak for myself too, there are two injuries where I don't sit on. One is the eye injury. The other is, I feel it's a cardiac, life and death, and the head injuries. If you let's make it three. But definitely cardiac, concussion, I still manage. Cardiac, first aid, shift the patient. CPR if required. Eye, just give first aid, protect the eye and don't try to do anything, even if you know about it, unless like, something has been gouged or something, give the first aid and immediately get an eye referral. Get the specialist to see. Because if the person loses eyesight, there's nothing we can do about it. But if the player has reached the proper person, the specialist properly, I've seen a lot of retinal detachment. I've seen a lot of corneal abrasions, which if neglected can lead to partial blindness or blindness in injuries. So we need to take home message for the eye injuries would be definitely, immediately, moment you suspect, don't give eye drops left, right, and center unnecessarily and think that, okay, if theek nahi hota, if it doesn't become okay, then I'll refer. Just refer immediately, whether the player is a millionaire or whether the player is a very poor person from a very poor club. That would be my take-home message from eye injuries. Rest of the eye injuries, of course, in your kit bag, you should always have those eye gauze. You should have tears refresh eardrops, small little antibiotic maybe, and protect. And you should have what you should have in your first aid. Okay. Nasal injuries again are very common. So they've already been discussed previously also. So here again, nasal injury is very easy when you think of somebody just having a nasal injury just because of a small hit. But just a few days back too, I attended a patient who kept coming to me and he says ki halka touching pe bhi mera bleeding hota rehta hai. So he was managed in my absence, and when he came to me, I said, let's work him up properly. So when I worked him up, there were so many issues with his knees. There were polyps, there was severe DNS. Okay, so we had to do a turbinectomy, we had to do a polypectomy. And after that, the person started boxing and now he gets punched in the nose and he doesn't bleed easily. So what happens is you have an excellent boxer, outstanding boxer, he's in the ring, he's been hit. Say like a footballer, so if he's coming bleeding, he's going to be asked to leave the ground. So we should also evaluate properly. So like I said, again, if the moment you suspect that more than one or two episodes of epistaxis and you think that even slight touch has led to thing, please refer him to the ENT specialist, get the laryngoscopy done, get the CT scan done of the paranasal sinuses in the nose, and let the ENT specialist see them and rule out for all the other medical causes of bleeding. And whenever one gets injured, we have this tendency, another player will come, hato, I will do it. And they'll try to realign the fracture or everything. And then I think basically if there's any deformity, they should go and see a doctor. That would be the message. And of course, spine injuries also has been already spoken before this. They are very common in football players. But the moment you get a spinal injury, you suspect a spine injury, always we say is you have to follow the doctor ABC and you have to also immobilize. So you should be having all the first aid kit in your bag. which is going to also immobilize the neck. Immobilize the neck, and you need to transfer and shift the patient immediately properly. So I think now most of the international level of football, they require you to have a trauma and a spine board if you're having a match, not just a normal stretcher. So as you can see in this picture, brachial plexus injuries, stringers, burners, pinch nerves are very common in football injuries, especially, we don't notice it. They come to you after 2 days and they say, I've got stiffness and injuries. There was no clear-cut injury at that time, fall on an outstretched hand, and somebody maybe pull the shoulder, and then you find out that they're facing some numbness, and you're doing all the basic tests. You're not getting any findings. I suggest that go for an MRI and go for an NCV definitely, or an EMG. I have seen a few cases of upper brachial plexus injuries. And then of course, the only thing that you need to do is send it across to the neurosurgeon, neurologist, and then we look at how much the damage is there at especially the axonal nerve damage, if any, and then you need to immobilize and give whatever neurological supplements, or, like I give the patient rest and try not to move or damage that further, so to prevent further damage. Because what happens is over a period of time, there's a brachial plexus injury, but because you're playing football, if it's not, especially your non-dominant hand, and he will just avoid throwing the ball when the ball goes out, he will not throw the ball, and then he'll keep on playing. And after a month or so, you realize that you're seeing, changes in the shoulder. You're seeing that the muscle has degenerated. You've lost muscle mass. You've lost strength. You've lost power. By the time, sometimes it becomes a little bit late. So we need to also, like I already mentioned, we should be paying attention to deltoid biceps and external rotators, which are the most muscles affected. So sometimes the patient just comes to you saying that, oh, I'm feeling a bit weak. So please keep this in mind, that we may have a brachial plexus injury. Acromioclavicular injuries, joint injuries, like any other injury of the AC joint, which is there. And because I've seen that all these topics have been actually taught, so there was no point for me to revise on it. But just remember that normally I have a very simple thing that sometimes you always just ask the player to go across his hand, the opposite side, and you can always look for AC joint injuries confirmed on the X-ray definitely, and on an MRI or a CT scan. But moment you suspect, initially most of the commoners is the AC grade 1, grade 2, which can be taken care of maybe just by simple taping, the Price protocol. And especially in football, because the individual is not going to, unless he's going to throw the ball, or if he's a goalkeeper, you can still manage continuing playing, but ensure that you strap up the injury properly. And if the patient still does not respond well to conservative management, kindly send him to the orthopedician immediately. Here's shoulder contusion, which we already spoke about. Normally this happens when we have a lot of tackles and fall on the ground. So what happens normally is most of the players, once they have this small little contusion, and they have this habit, most of the players, if there's an injury, to get a massage done. So we try and avoid massage, especially. What I would do basically is just give it rest, follow the Price protocol, use a sofromycin ointment on it, or a Bactroban if you find any raw wound. And once the wound starts healing, you could maybe use coconut oil or anything and just rubbing on it, but no massage. Just you have to be very clear with the players that he should not go for massage. And of course, if there's fluid, or there's any swelling or cystic swelling over there, I think once we investigate, we find if there's any fluid inside, we can, or blood or hematoma, we can get a possible aspiration. Again, glenohumeral instability is also one of the very commonest injuries, and of course, dislocation. And as we all know, what happens with dislocation is that we have a lot of people on the ground, and once especially you have a dislocation, we try to reduce it immediately. I believe if there's no expert out there, we should discourage people to relocate it immediately, because what happens when you try to relocate it, we end up causing a slap lesion, we end up causing a Hill-Sachs lesion, we definitely have a capsular injury, and in the long run, then the player will end up having to undergo surgery or a recurrent dislocation. So we need to ensure nowadays that what I do with most players, if I cannot do it in one set easily, after giving a muscle relaxant and a painkiller, I immediately immobilize the patient, take him to the hospital, and we do it under GA. So, I mean, most of the injuries, elbow injuries, I was checking out there, they've already been covered for. So I think I will desist from wasting a little bit of time here. Because spondylolisthesis also was discussed right now. Back injury was discussed. It's almost the same like all other sports. See, but in cricket, you rarely have trauma. Badminton, you rarely have contact. But football is a high contact, high speed game. So definitely some of the injuries we're going to face are going to be because of contacts. One of the injuries which is common, which normally one doesn't discuss, is a hip pointer. A hip pointer is an injury that occurs when there is a direct contact with the iliac crest or the pelvis. This can occur by getting hit or falling onto your side and landing on a hard surface. This is typically the result of compression of soft tissue between a hard object and the iliac crest. And remember, in India, what happens is, if you have played football at every level, it's only at the international level or maybe state district level that you have good grounds. Most of the grounds are like half football pitch, half cricket pitch, half gilli danda pitch, and then you have hard surface, rough surface. The ground is not really good, and when you fall, you are definitely going to get injured compared to when you fall getting injured on a good pitch. So always the pitches also have to be taken care of, and if you are going to be a part of the support staff, either as a doctor, as a physio, as a trainer, or even as a coach, I believe that as much as possible, when you fix your matches, fix matlab not match fixing, fix the match schedule. Try to see if you can get them to play the match and explain to them that this ground is going to be dangerous or injurious to all of us. So when I was playing football, once I got such a bad ankle injury, I was playing on that pitch, is in Shillong, Polo Grounds, beautiful football pitch. I was playing on the pitch regularly. So never thought. What happened was 2 nights before they had a rock show. So when they had a rock show, they dug up and they put, for the stands. So they made such big holes and they never filled it back. And we as players didn't know. And that day, 2 players from the opposite team and me and one of the players were injured, and I was out for a month. It was the very same ground you were running 3 days back, when you were practicing, and then you were playing a match on a Sunday, and there were so many holes in a perfect pitch, because in India, permission can be given for everything. So we need to look at that. I always believe inspect the ground first if you're going to play a match, and that's what I do with most of my teams now. Like, we get invitational tournaments, and then if we feel that the ground is not up to the mark, we get a neutral ground, or we ask them to come to our ground. And even when we talk about football injuries, same happens with the wrestling players, the volleyball players, when they decide to go and play football. Is because they just play on any.
Hello.
They don't get up to the ground. Hello.
Hello.
Yes. Someone speaking to me?
Please carry on. I think there is a disturbance.
Okay.
Sorry.
So I like I said today, because I noticed that all the injuries have actually been covered. So that's why I said I'm going to talk more about certain things that we generally, as doctors and as support staffs, we don't talk about. So hip pointers result, like we said, in immediate intense pain and localized tenderness over the iliac crest or the pelvic bone. There will usually be significant bruising and swelling around the front, outside, inside of the hip. Due to bleeding and swelling, movement of the hip will usually be limited and painful. You decrease the range of motion, and weakness also typically seen. Of course, how are you going to manage it? You give a protected weight bearing. Keep crutches. I always suggest keep crutches where you're practicing. Also keep crutches immediately, either an elbow crutch or a proper crutch. And also you have the trauma board and a proper simple scoop stretcher. where you can actually get the player out properly. And because we end up, when he's walking from one corner of the pitch to another pitch with a hip pointer or with any hip injury or ankle injury, it is going to be worsened. And then number of times, the 2-3 players, we pull them out, you know. And generally what happens is, if the injury is prolonged, we get the player out immediately over there. In matches, in professional matches, of course, the stretchers and the team are going to come, but we're talking about in practice. So in practice with low level teams, if you're playing, these things are not provided for. Just ensure that, you know, and most of the time, even if one gets injured, the coach or the players, "Hey, nothing happens, and they'll try to pull and push the player and try to replace, okay, nas khich gaya, and let's relocate or replace it. And we actually then now from grade 1, 2, it's gone to grade 3 or complete rupture of whatever the injury was, whether it's a muscle or a tendon or a ligament. So we need to educate basically our lower level coaches and players for this. So the progressive range of motion and strengthening are initiated as pain resolves. We all know once the injury comes, then we are firefighting. I mean, all physios and doctors here know that they're going to manage and how to manage them. So return to play is allowed when full painless range of motion and strength have returned. Again, the quadriceps strain and contusion is the most common because, like I spoke some time back when I said the quadriceps is generally always, this is one of the areas where you're going to get kicked. One is the ankle, the shin, and this is where you're going to get kicked the most. And especially when you're colliding, sometimes the knee of the other player, and you know, when someone kicks you, it's still not as the knee hitting your quadriceps. I have been kicked and kneed many times when we were playing, so I know and understand the pain. So just ensure in this case that you diagnose it early and ensure that they don't go for massage, as we end up with myositis ossificans. And as you all know here, the support staff will go to train. We do the price protocol initially, go for the police protocol, and then of course you strap them up. And if you look, this is what I was talking about, is this is how we evacuate the player generally. So it would be nice if we had a stretcher here.
కొంచెం తోలిపోయింది ఇది.
And
Dr. Kane.
yeah, I was muted. Okay.
Yeah, mistakenly you were muted.
No problem.
Yeah,
No problem. You mute all, and then it's okay. We can get to know. Hamstring again is one of the commonest injuries that we see in football, and always, like some time back, you know, Dr. Shibu all said that proprioception is so important, balance is so important. When we say balance and proprioception, I also always talk about balance of the muscles. Hamstring, top level footballers, we work on Nordic hamstring strength, and so many other machines. They have a proper gym with very good smooth machines. If you go to most of the general gyms, you will see that there is no good hamstring machine. So Nordic, no one does it because it's a very boring kind of exercise. And then initially it does hurt, it causes pain. So unless you're doing it regularly, but it's so easy to work on the quadriceps, you know, because you're doing squats, works on the quadriceps, you're running, works on the quadriceps. You have all those lovely machines to work on the quadriceps, but the hamstring is so boring, you're turning on your face. So excepting for elite athletes, most of the gyms, also elite gyms, don't have good hamstring machines. So if you're having a gym for your club, ensure that you have good hamstring machines which work properly, because that is one of the most boring. And we all know, you know, like if you go to a normal gym, you see everybody works on the biceps, they don't work on the triceps, they work on the quads, they don't work on the hams. So and running, quadriceps is being used, simple, balance. So there's most of the time the injury is because of imbalance between the quadriceps and the hamstrings. So I believe that if you go to the FIFA website and you look at the Nordic hamstring curl and other exercises, please work on your hamstring, on the hamstrings of your players, and strengthen it to balance the muscle, and you will definitely get lesser and lesser hamstring issues. So I also did this with my football team, and we got next to almost 50% reduction of hamstring injuries, taking care of the other load. And the few other hamstring injuries that we had, intrinsic type, were simply because the person had gone on leave for more than a month or so. He came back within 1 or 2 days, he went all out and playing, and that's when he got injured. And that is what happens when you don't have a professional, a doctor or a team. This is what happens with a lot of club level players. You know, they can't even afford a doctor or a physio also in the team. So it's very important to educate the trainers or the assistant coaches and the coaches for this. I think I will skip this because everybody would know, and then of course it will of course be of no use to other than the support staff, and the support staff, everybody knows how to examine the hamstring. Most of the time for the hamstring also, when someone gets injured in a match, like you see, we tend to tape it up and let them go or give them a compression support. But I believe that if someone is complaining of severe pain, we should not forcefully put them on the ground. It's not unlike a badminton where the individual has to play, or a tennis. In football, at least there is something called a replacement, something called the extras. So they can be replaced. He can be replaced, right? And the other thing is also that when he recovers, when his testing is done, you actually reduce the damage. So you get him off the pitch immediately if he's injured. Don't forcefully tape them up, give them spray and ice spray and put them back on the ground, even if he's good. In badminton, what happens sometimes, because the individual is playing semi-final, final, and he feels that, okay, I can finish off the ball early and, you know, protect myself, but not going towards that side. Like say in a tennis player, you know, I'm not going to go inside out because that's going to stress my hamstring. I'm not going to stretch for the drop shots. So he's going to adjust for an individual game and he'll try and finish the game. And he'll protect his thing. But in football, he'll be of no use being in the team anyway. Standing, he's going to kick and he's going to get further injured. And then there's a replacement, substitute. So you can substitute. So I think these things you should always discuss with your coaches also when you're on the pitch. Be a little bit proactive on that. And always ensure that they have a proper readiness for return to competition. Because there's a huge difference in practice. Sometimes a person feels I'm fit in practice, because in practice everything is controlled. The drills are controlled, the passing is controlled, you know, the play is controlled. He's playing with his fellow people or his fellow teammates. But when you're going for a competition, a lot of different dynamics happen in the game, which then what happens is, if the balance is improper, if the strength is improper, if he's not healed properly, if he's not match fit, he's going to get worse. So instead of now we had a layoff of say 1 week or 2 weeks, now we'll end up having a layoff of 3 months. The season is gone. So we've lost the player for that season.
Yeah, Ken, I think we are running out of time, so we can start taking questions.
I'll go quickly. Yeah. Can I just quickly go?
Yeah.
And groin strain again, everybody has already. That's what I said. The advantage is all these injuries were anyways covered. So just ensure for groin strains, when you have a criteria for return to sports, is equal muscle strength of adductors, abductors, flexors, extensors on MMT, full pain-free range of motion, ability to perform all sport-specific functional drills at full speed without pain. It's only then you let them go back. So knee injuries have already, ACL injuries have already been covered. So just remember that the ACL injuries, like we said, are the commonest. We all need to talk about. So to prevent ACL injuries and knee injuries, I think what the coaching system has to be developed in such a way, besides the proper training, because normally you train generally and you train only one, you play only sports, you have a little bit of drills, but the things like perturbation, balance, proprioception, they talked about, you know, sports specific training, and then of course cross training also. So you work on like Dr. Shibu also added one thing about the reflex, where he had that machine where, you know, you work on the reflexes. Even that can be done. So you can have a lot of work you need to do now. I think we should focus a lot on the injury prevention rather than, you know, firefighting for the injuries. So I'll just wind up with the football injury prevention tips. Perform proper warm-up and cool-down routines. Follow the FIFA 11 Plus program. It's available in posters on the net, freely available, costless, and it's priceless. Consistently incorporate strength training and stretching. Hydrate adequately to maintain health and minimize cramps. Stay active during off-season to prepare for return to sports in the season and pre-season. Every team should ensure that you have a pre-season. Most teams straight away get the players together and they start off the season. So ensure that you have a pre-season. Wear properly fitted protective equipment such as helmet, pads, and mouth guard. You know, there are a few people who used to get hit, especially my defenders. So because I worked with hockey in the Olympics, I just thought, why not advise mouth guards to my players, especially the defenders? And actually, it helped. We don't use a helmet here, I'm sorry. This was just added by default. But we use mouth guards and it did help the oral cavity damage. And of course, the equipment is so important. Like my goalkeepers, sometimes they use poor quality gloves, and they get injured there also. So if they have good fitted gloves and proper training, I'm sure we can have a very good and pre-season health and wellness evaluation, which Dr. Shibu again mentioned for his badminton. In football, international level football, club football, we all know it's important. We have PP, CMA, or we have a pre-participation examination, pre-participation medical. And that is so important because you look at medical, surgical, and thing. We have sudden cardiac death screening. We have you evaluate all the joints and knees, and any weaknesses are there, you can work on the pre-season, so you can actually prevent the injuries. And of course, if you have any doubt, speak with your sports medicine professionals or athletic trainer if you have any concerns. And of course, the advantage of having such conferences and such coordination together here is that now we know, like those people who never knew who were the different sports medicine, like now people know that if you want to go Saudi Arabia or Dubai or that side of the world, Dr. Shibu is there, we know that. Okay, if you go to Delhi, we know who's there. Dr. Ahuja is there. If you go down south, so you kind of know. This is the advantage of having this conference. And thank you so much, Dr. Vikram, for putting everybody on this platform. So I'll wind off with just return to sport. At some point in the recovery process, just remember the athletes return to strength and conditioning programs, and they resume sport-specific activities in preparation for return to play. And the transition is very important. First, although the athlete may have recovered in medical terms, we have, when we examine them in the clinic, the flexibility is good, the range of motion is good, functional strength, pain is good, absolutely fine. But we have to put them on the pitch and check them out. So the return to play is defined as the process of deciding when an injured or ill athlete may safely return to practice or competition. Early return to training and sport are considered sensible. So we need to plan that. So once an athlete has been medically cleared to return to play, there are some fundamental steps that need to be followed. The footballer has to fulfill the fitness standards of the team he is returning to. He needs to pass some skill-specific tests applicable to his playing position. The player may then begin to practice with the team, and exposure to the match situation should be gradual, with the match time gradually increasing. So I think since we are running short of time, thank you so much for a very patient hearing, and I'm ready to take on any questions, if any.
Yeah, thanks a lot, Dr. Kane. And there's one question regarding Bell's palsy. I don't know how this is related to your talk, but do you want to take this? If Bell's palsy, sir, then how much time would have taken his recovery, and tell best exercises? Ken, you have to unmute yourself, please.
Okay. So I think when you talk about Bell's palsy, unless the individual is actually complaining of pain, in some cases I've seen patients where they complain of pain also. So others, if the individual is having Bell's palsy, and are you talking about a footballer? Are you talking about what sport? So, but if any sport, Bell's palsy, see, if he's going to play with his feet, and if it's not affecting his other functions, when it's not very severe. So I think you need to take the neurologist's opinion, and also looking at the functional ability of the player. And then you can allow that person to play, start with practice and all that. If it's not affecting him, I don't think so it's an issue. Definitely not an issue. And continue with the medications. Ensure that they don't result in an ADRV, anti-doping rule violation. I think that's not an issue. We have players with ADRV also who play. With Bell's palsy who play. But that depends on the severity.
Okay, thank you, Ken. Thank you. So we can have Dr. Ashok Ahuja for a quick comment and a quick question from Muhammad Amjad. Amjad, just one question, no leading questions further. So be quick.
Yeah. Okay, sir. Sir, thanks a lot for your wonderful session. Sir, regarding FIFA 11 injury prevention program, the studies has proven that if the FIFA is adopted with the Nordic hamstring muscle carousel training, it has reduced the injury rate from 49 to 50%. Hamstring injury rate.
Yes.
But the problem here, sir, the compliance rate is very less. So what are the measures to be taken to increase the compliance to Nordic hamstring curls?
Yeah, so I think if you were listening to me in the first 3-4 slides itself, I talked about the compliance.
Yeah.
And I said again, why the compliance is not there is because you have players, international players, coaches, they've been following a certain pattern, certain habit. Okay. And I also talked to you that you forget the Nordic. the hamstring exercises are very boring. Unless you're an elite athlete and you can actually go down and it doesn't hurt you. Ask a beginner to do a Nordic. I have seen a lot of people go into Nordic and actually straining the hamstring.
Yeah, I cannot do.
Going for the Nordic without support, without proper technique. So it's very important first to teach the Nordic, go grade it slowly, and first explain to them. And you see, one thing I've seen is very good. It's like when you're working, see, there are 2-3 things. If you take the name of an international player, see, supposing like if I am talking to a badminton player, he's not interested in what Usain Bolt is saying regarding his injury, but he'll definitely be interested in what Lee Chong Wei is saying, what Lin Dan is saying. You got my point? So because sports specific. So what happens is so that is why if you find out injuries of top level players, how they are rehabilitating. So what I do is with footballers, I show them Messi's video, I show them Liverpool's video, I show them how they're doing the pre-season training, I make videos. So you will have to be a little bit proactive to get the compliance with their players, because remember, they are not bothered about your research. They are not bothered about your DM, your MCH, your fellowships, your how many research papers you produced. Okay, they are interested in what their local language, in what they understand, because they have certain habits. And also because, like I said, most of our coaches and players are actually in India are not educated. So we have to then adjust. We cannot keep on complaining that it's not going to happen. So this is the best way. And like I already spoke, I said, get good machines. Get good machines if your club can afford it. Otherwise, you have your hamstrings, and build, even for the Nordic, I suggest go for TheraBands and TheraBunes and TheraLoops, work on the muscles before you go into Nordic. And initial Nordic, definitely support the athlete. Don't let them go independent. Show them partner. One player will partner. Okay, I'll do 6-7 reps and just go by the 10% increment per week. Results are there. They're doing fantastic.
Okay, thank you, Ken. And if Dr. Ashok Ahuja sir can add up.
Yeah, thank you, Dr. Vikram. I think just continuing with the discussion as far as the Nordic hamstring, because hamstring is, I think, one of the most common muscles which gets strained over there. My advice always, as far as Nordic curling, when we do it, is, and this is my in-exercise prescription, is that I tell my athlete to hold it at 45 degrees, at 90 degrees, and at 120 degrees for 5 seconds each or so. I totally agree with my dear colleague Ken that a lot of people are not aware of it. We don't have the equipment also. For in those cases, at least I tell my athlete, that to use 2 kg, 3 kg iron cuff weights also, keep standing and then just flex your knees on that. So even that also, a hamstring curl starts over there, but with the resistance only. Of course, we have the TheraBands, TheraTubes, TheraLoops, all over there. They can also help, This is just a small comment that at different angles, at different degrees, this is what the isokinetics tells us also, that if we just tell them that how to hold the hamstring at that particular angles, it really helps in the rehabilitation, and a faster recovery takes place from a hamstring strain, which is, I always call that this is an enigma of every athlete all over the world also. I think every athlete suffers from that. Before I just give my concluding remarks, Vikram, I think being a teacher, there was a question on the Bell's palsy also. Well, I know it's a very rare thing to happen, but after all, every athlete is a normal human being, and he suffers from these things also. So masticating exercises for them, what I do or recommend is that giving them balloons, giving them chewing gums, even that also will help over there, not in the acute stages, but ultimately. So idea is to have the facial paralysis, growing your beads, even that also helps over there. But I think the balloons and chewing gums really help into that. It is more of the cosmetic in case it becomes a chronic Bell's palsy. Of course, in acute, as Ken said, we need to be careful as far as the ADRY is concerned, because corticosteroids are normally prescribed over there. We see a lot of cases, mind you, in athletic population, and I have seen it myself over my career, is when we have gone into extreme cold conditions. I remember I was in Finland and in Norway, and we had taken our hockey team over there for one of the explorers from a high altitude training point of view. And we had 2 cases of a Bell's palsy coming up over there. But fortunately, any cold air can also act as a stimulus also. That was the cause that we get it, because probably they were not wearing their caps fully covered over there. These are my 2 comments on the questions that were asked over there. I think it has been a fantastic beginning in this today. Today is one of the most crucial days. And I think in my talk, I always say that the Sunday is one of the most busiest days for all sports physicians also. I know yesterday we all, I think, had the look at the ISL final, and we really enjoyed that over there. My carry home messages out of these 3 presentations that we have today, starting from Badri, Shibu, and Ken. The key home message is know your athlete. You got to know your athlete very well. Pre-participation examination is a must, these are the ignored aspects in our Indian context also, and we need to incorporate that. Every athlete is a human pathology. You see, you saw the number of, he goes over there in his career, 8 to 10 years of the career, he will be going through. Every day, there is going to be some niggle, there is going to be some pain. If there is no pain, there is not going to be gain. That is part of the stimulus. It's a part of the fatigue stimulus, which is essentially required to be given to the athlete. Only thing is that when it becomes, that micro trauma becomes a macro trauma, then of course we result into the injury also. So the key home is that the fitness schedules have to be maintained. Whether we talk in the rehabilitation or we talk in the prevention also. Strength, balance, proprioception, neuromuscular coordination are the main areas on which we need to focus it all the time whenever we talk with the athletes. Talk to the athlete in their language. Do not talk of hi-fi things over there. He is not interested as to where is the attachment, where is the insertion of my muscle over there. He is interested that where the pain is also. So I think we need to, I will continue with it. I know we have a lot of very next on the line, we got beautiful experts coming up with a vast knowledge also, and I'll keep on pumping over there. Thank you very much.
Yeah, thanks a lot, sir. Thanks a lot. So Subirji, now I think both the speakers are here. Akshat is here, and I think Dr. Aradhana has also joined. So you go ahead.
Thank you, Dr. Ashok Ahuja, sir, Dr. Kane. And I think it is a beautiful explanation, as Dr. Ahuja rightly said, that you need to go and assess the pre-assessment. It is perfect. And the data in every player and the team coaches will learn from the doctors and the physios when the doctors and physios are practically or physically present in the ground or the field. That is the best part which we are missing. So thank you, sir. So now may I request Dr. Aradhana Sharma. Are you ready, madam?
Yes, I'm ready.
Yeah, Dr. Aradhana, Madam Sharma ji is one of the leading performance nutritionists in India with 21 years of experience in India and the USA. As a senior consultant, she is associated with the Directorate of Sports and Youth Welfare, Bhopal. Tata Trust Sports and Olympic Quest. She is an adjunct faculty for MSc program in Manipal University. She has also worked with the Army Mission Olympic Wing. She worked with P. Gopichand Academy, then Tata Steel Sports Division. Dr. Aradhana, Senior Sports Science Consultant, Directorate of Youth and Welfare, Madhya Pradesh, expert trainer, OGQ, and whatnot. She is adjunct faculty in the Department of Exercise and Sports Science, Manipal University. So without wasting the time, I think we are running almost an hour late. So madam, please take over the mic and you are welcome.
Thank you so much. I will, without wasting time, I'll start sharing my screen. So we'll try to cover up as much as I can within the given time slot.
Thank you. Welcome.
This is visible, right?
Yeah, perfect.
Okay. So nutrition and injury management, as of lately, I have seen now people are getting more aware about nutrition also plays a role. but when I moved to India around 10 years back, that time we were, the athletes I saw during injury and rehabilitation, it was an issue because they were not following any diet. They were not making any changes in the diet. But now I'm really happy to see that the information out there is more, and the compliance is also growing. We are not yet there where we should be, but it's growing day by day. So before we talk about injury, it's my job to talk about that we need to prevent the injuries, because why to even go in the injury if you have a chance to prevent it? So prevention is always better than cure. So there are few things I'll mention here, that carbs and proteins are top priorities. So no brainer. I'm pretty sure that many of the speakers must have talked about various parts of nutrition, because it comes the sports science overlaps now and then, so they must have talked, but there are few things that I need to just re-emphasizes. So the second point here, when carbohydrate stores are low, the body breaks down muscle protein. So one thing, see, we all understand being into sports science profession, but it's difficult to make the coaches and the athletes understand many a times the science of food also. Now, what they think that they just need to keep taking protein and they miss out on carbohydrate, even, their regular training sessions. And that especially happens in the power sports. पावर स्पोर्ट में उनको लगता है कि प्रोटीन ही ज्यादा खाते रहेंगे तो पावर ज्यादा आता रहेगा, एंड उससे एनर्जी भी मिल जाती है. मोस्ट ऑफ द पीपल नो दैट प्रोटीन कैन प्रोवाइड यू एनर्जी, इट प्रोवाइड्स यू 4 कैलोरीज, सो डज कार्बोहाइड्रेट. सो दे थिंक हम प्रोटीन ही खाते रहते हैं, एनर्जी मिलती रहेगी. बट द इश्यू इज आपका बॉडी का जो प्रेफर्ड सोर्स है, योर बॉडी प्रेफर्स कार्बोहाइड्रेट एंड फैट for providing the energy while you're working out. Now, when protein is there, it's supposed to build the muscles. If you are on a prolonged diet which lacks carbohydrate or fat also for that matter, then your body looks into breaking down protein from your muscles. So this is one thing, and I have personally seen this with the athletes, especially the power sports, where they go overboard on protein consumption. So in that case, their carbohydrate consumption is less, whereas carbohydrate always stays the preferred source for the body, not only for the body, but also for the brain. So that's one thing we need to look into, that carbs and proteins are top priorities, but because of protein, we cannot put the poor carbohydrate on the back seat. Then protein does break down in both the exercises, both kind of endurance and strength, and of course in intermittent exercises too. But then adequate dietary protein will take care of building the muscles again and providing you all the amino acids. But then again, carbohydrate will come at the top. So now, to help prevent injury, fuel up with both carbohydrate and protein 1 to 2 hours before your workout, and again within 30 minutes after. Now, this is a generalized sports nutrition principle that we have to follow, but it goes different for different sports, different kind of sports. But the general guideline is about 1 to 2 hours before a competition, one needs to make sure that they are taking a combination of carbohydrate and protein. Before training, carbohydrate has to be higher, protein has to be lower. After training or after competition, the recovery window is usually 45 minutes, the window of opportunity. But in India, I want to bring it even closer to make it only 30 minutes, because I see when I give 45 minutes time to my athletes, they relax, aram se they go to 1 hour. So that's why it is important to make the window shorter, so that they are actually ready with their after training or after competition snack. Now that has to be again a combination of protein and carbohydrate. Carbohydrate for the quick replenishment of the glycogen, and protein, of course, to take care of whatever wear and tear your muscles have gone through during the training. So, and again, we need to pay attention to hydration, because that is something many of us miss out. And I still see, even in elite athletes, hydration needs to be talked about by everyone who's dealing with them. So because if a person is dehydrated, it's going to create the load on your physiological system. Your heart rate is going to go up. And there are, different formulas for different people, how they can take care of their personalized hydration. Then electrolyte imbalance is another thing, which can actually push you towards the injury, because we need to maintain all those electrolytes, sodium, chloride, potassium, and all that. So that is, again, very important. if a person is, because of dehydration, if a person is getting fatigued faster, अगर बहुत जल्दी थकने लग रहा है मसल, so थके हुए मसल्स को इंजरी होने का चांसेस ज्यादा होता है. मस्कुलर इंड्योरेंस आपका रहेगा. I don't need to talk much about that. I'm pretty sure that must have been covered in other sessions. लेकिन न्यूट्रिशन से रिलेटेड जो है, आप कुछ भी खाएं उसके पहले आप क्या पी रहे हैं उस पर ध्यान होना जरूरी है. It's not only about nutrients, the solid nutrients and food, it's also about what you are drinking before and during and after your training and competition. अगर prolonged period तक severe dehydration रहता है तो आपका mental focus भी कम होने लगता है. Your mind and your body's coordination gets to disturb. So that's again another thing, more chances of making error, more chances of getting injured. So this is why hydration is really, really important, that to prevent injuries, what we need to take care of. There are lots of muscles injuries, there are ligament tendon injuries that can be due to dehydration. I have not listed much detailed scientific, but the whole scientific process, the water, the electrolyte imbalance, and how your the heart rate increases along with as you go further into dehydration. तो ये एक बहुत जरूरी चीज है जो ये टॉप प्रायोरिटी में होना चाहिए कि a person has to be hydrated for a optimal training and performance in the competition. Important micronutrients to care for in terms of prevention of injuries also. So generally vitamin C and E are something that we need to look into. Now when I talk about this, by no means मैं ये कह रही हूँ कि आप विटामिन सी और ई का टैबलेट लेना चालू कर दीजिए. विटामिन सी इज स्टिल ओके क्योंकि वाटर सॉल्युबल विटामिन है, आपका बॉडी से वॉश आउट हो जाता है अगर एक्स्ट्रा होता है. विटामिन ई आपका बॉडी में स्टोर होता है क्योंकि फैट सॉल्युबल विटामिन है. तो हैविंग सेड दैट, मैं अगर कह रही हूँ कि विटामिन सी और ई जरूरी होता है आपका, क्योंकि ये एंटीऑक्सीडेंट्स हैं. कोई भी एथलीट हर दिन ट्रेनिंग कर रहा है, मल्टीपल टाइम्स ट्रेनिंग कर रहा है, तो उनका बॉडी में ऑक्सीडेटिव स्ट्रेस ज्यादा होता है. दे आर पुटिंग देयर बॉडी अंडर स्ट्रेस ओवर एंड ओवर. ऑफ कोर्स वो सब हेल्दी पॉपुलेशन है तो उनका बॉडी को टू फाइट ऑफ दैट फ्री रेडिकल्स वो कैपेसिटी ज्यादा होती है, बट ड्यूटी इज टू प्रोवाइड द न्यूट्रिएंट्स जो वो ऑक्सीडेटिव स्ट्रेस को फाइट ऑफ कर सके. तो इसलिए विटामिन सी और विटामिन ई जनरली हम लोग बोलते हैं कि ये काफी हेल्पफुल हैं. मैंने यहाँ पे जो नेचुरल सोर्सेज हैं वो लिस्ट किए हैं क्योंकि मैं देख रही हूँ अभी काफी एथलीट्स विदाउट गिविंग अ सेकेंड थॉट जाके बाजार से और विटामिन ई का टैबलेट खरीद के लाते हैं, 2-2, 3-3 टैबलेट एक दिन में ले रहे हैं, विच इज नॉट राइट बिकॉज विटामिन ई टॉक्सिसिटी कैन हैपन इन बॉडी. तो इसलिए यहाँ पे जो नेचुरल सोर्सेज हैं विटामिन ई के लिए वो मैंने आपके लिए लिस्ट किया हुआ. आमंड्स में होता है, जनरली ड्राई फ्रूट्स में, ड्राई नट्स में होता है. आमंड्स हो गया, वॉलनट्स हो गया, उसके अंदर पाया जाता है. सनफ्लावर सीड्स जो होते हैं वो काफी अच्छा सोर्स है विटामिन ई का. व्हीट जैम एंड एवोकाडो. एवोकाडो ऑफ कोर्स इंडिया में हम उतना ज्यादा यूज नहीं करते हैं. नाउ हैविंग सेड दैट, इट्स नॉट लाइक कि एथलीट्स को जाके एवोकाडो ही लेके खाना है. देयर आर अदर सोर्सेज, सीड्स हैं, ड्राई नट्स हैं जिसके अंदर विटामिन ई होता है. तो अगेन इट्स नॉट रिक्वायर्ड कि इंजरी प्रिवेंशन के लिए आप जाके विटामिन सी का टैबलेट, ई का टैबलेट्स लेके खाना चालू कर दें. अनदर थिंग हियर, जो रिसर्च के थ्रू प्रूव किया गया है कि जनरली जो अपना कैल्शियम इंटेक का ध्यान नहीं रखते हैं एथलीट्स, उनमें नेचुरली वी ऑल नो कि लोअर बोन मिनरल डेंसिटी रहेगा और उसके कारण स्ट्रेस फ्रैक्चर के चांसेस ज्यादा होते हैं. और अगर प्रोलॉन्ग पीरियड के लिए भी अगर उनका हमने ध्यान नहीं दिया कैल्शियम इंटेक का, उस टाइम पे नेचुरली किसी भी इम्पैक्ट से उनका बॉडी, उनका बोन्स को फ्रैक्चर होने के चांसेस ज्यादा हैं. तो ये कुछ माइक्रो न्यूट्रिएंट्स हैं. मैक्रो में मैंने आपको बताया प्रोटीन और कार्बोहाइड्रेट बहुत इंपॉर्टेंट है इंजरी प्रिवेंशन के लिए, और ये कुछ माइक्रो न्यूट्रिएंट्स हैं जो अगेन इंजरी प्रिवेंशन के लिए ज्यादा इंपॉर्टेंट है. तो फिर रिहैब के टाइम में न्यूट्रिशन का इंपॉर्टेंस क्या है, मतलब व्हाई डू वी इवन केयर अबाउट दैट. तो उसके लिए एक छोटी सी चीज है कि रिहैबिलिटेशन में क्या होता है, जो रिकवरी प्रोसेस होती है उस टाइम आप अपने बॉडी के अंदर क्या डालते हो वो भी उतना इम्पोर्टेंट होता है कि आप बॉडी के ऊपर क्या लगा रहे हो. आपने ब्रेसेस लगा लिया, आपके जो दूसरे तरह के ट्रीटमेंट से जो आप एक्सटर्नली ले रहे हो अपने फिजियोथेरेपिस्ट से, अपने स्पोर्ट्स मेडिसिन स्पेशलिस्ट से, वो आपके ऊपर ट्रीटमेंट हो रहा है. लेकिन आप बॉडी के अंदर क्या डाल रहे हो ड्यूरिंग योर रिहेबिलिटेशन पीरियड, वो भी बहुत ज्यादा इम्पोर्टेंट है. तो साइंटिफिक कुछ फाइंडिंग्स है यहाँ पे, देयर इज एन नंबर ऑफ डेटा अवेलेबल, बट मैं उतना डीप उसमें नहीं जाना चाहती क्योंकि वो बहुत बोरिंग सेशन हो जाता है। तो कुछ मेन चीजें मैंने यहाँ पे लिस्ट आउट करी हैं। जो न्यूट्रिएंट्स मोस्ट ऑफन एसोसिएटेड विद पेन रिडक्शन एंड इंक्रीज रिकवरी फ्रॉम इसेंट्रिक एक्सरसाइज, उसमें प्रोटीन और अमीनो एसिड, दीज टू आर वेरी वेरी इंपॉर्टेंट। Along with that, anti-inflammatory compounds and antioxidants, जो मैंने already आपको बताया, vitamin C and E generally are very important even during rehabilitation. Pain reduction के लिए जो anti-inflammatory ingredients होते हैं, those are really important. Nutrients सबसे easy जो है हमारे Indian culture में, जो turmeric वाला milk, जो हल्दी वाला दूध होता है, उसको अब दुनिया गोल्डन लाटे के नाम से बेच रही है, लेकिन मैं अपने एथलीट्स को जनरली बोलती हूँ रिहैब में भी, एंड अदरवाइज आल्सो आई टेल देम इफ दे बिल्ड अ हैबिट ऑफ टेकिंग दिस curcumin और हल्दी वाला दूध in the night, that's really good. It has a very good anti-inflammatory property. The next year studies जो कुछ रिसर्च हुई है उसमें उन्होंने ये पता लगाया कि विटामिन डी का स्टेटस अगर अच्छा होता है बॉडी के अंदर, तो उनका जो स्पेशली ये वाला जो मैंने इधर पेपर कोट किया है वो ACL सर्जरी के ऊपर था, जो आपका एंटीरियर क्रूशिएट लिगामेंट होता है उसके सर्जरी के ऊपर इन्होंने स्टडी किया था। तो अगर विटामिन डी का स्टेटस आपके बॉडी में कैसे स्टेटस होता है, एक होता है लो, एक होता है इनसफिशिएंट, देन यू कम इनटू अ नॉर्मल रेंज एंड देन वेरी हाई। तो आप नॉर्मल से हाई रेंज की तरफ अगर रहोगे ड्यूरिंग योर रिहेबिलिटेशन फॉर ACL, so it was found to be really good at help to enhance the strength and recovery after the surgery. So this is vitamin D is something one needs to look into uska intake jab wo rehab mein hote hain.
क्या बोलते हैं डाइट के बारे में सीखा।
Then next is essential fatty acids like omega-3 fatty acids are required to build and repair cell membrane. So again इन केस आपके पास गुड क्वालिटी का फिश अवेलेबल नहीं है, क्योंकि जनरली उसके अंदर होता है आपका जो ओमेगा-3 एंड ओमेगा-6 होता है, वो दोनों फूड आपको कंबाइन करना है आपके डाइट के अंदर ड्यूरिंग रिहैब। इफ यू डोंट हैव गुड क्वालिटी फिश विच इज जनरली मैक्रेल होता है, ट्यूना होता है, उसके अंदर हेरिंग होता है, इंडिया में हर जगह अवेलेबल नहीं होता है, in that case we tell them to take a omega-3 supplements during rehabilitation only. They don't have to stick to that supplement throughout. If they can have natural sources of omega-3s also and omega-6 also, आपका flaxseed हो गया, chia seeds हो गया, जो dry nuts होते हैं, walnuts, almonds, all that, सबके अंदर good fatty acids जिसको हम बोलते हैं वो present होता है. Next is studies show that inadequate zinc from the diet can delay wound healing. So this is about wound healing I'm talking. It's not about the fracture and all that. So when it's about any कोई wound हुआ है during a training or competition, उस time पे उनको not only vitamin C, but then zinc also has to be there in their regular diet to make sure that they have enough availability of zinc to help with the wound healing. अभी कुछ फैक्ट्स हैं जो रिहैब के टाइम पे, एंड अगेन आई एम स्ट्रिक्टली टॉकिंग अबाउट न्यूट्रिशन रिलेटेड फैक्ट्स ओनली, जो हमको रिहैब के टाइम पे ध्यान रखना है. सो अभी आप अगर ये छोटा सा फोटो देखोगे, इसमें बीच में जो विकेड लुकिंग फ्री रेडिकल है, वी नीड टू हैंडल दैट मोर ड्यूरिंग आवर रिहेबिलिटेशन. सो दैट्स हाउ ग्रीन में हम दिखाते हैं एंटीऑक्सीडेंट हु इज एक्चुअली एक्सटेंडिंग अ हेल्पिंग हैंड. सो ऑप्टिमल न्यूट्रिशन प्लेज इंपॉर्टेंट रोल इन कंट्रोलिंग इन्फ्लेमेशन, providing important nutrition for rebuilding injured tissue. क्या होता है कि आप ऊपर से ट्रीटमेंट ले रहे हैं, आप उसके लिए अलग, अगर आपको मसल स्प्रेन है या आपका अगर बोन्स का भी वो है, आपका सर्जरी हो गया एंड ऑल दैट, उसके बाद आपको रिहैब के टाइम में मेक श्योर करना है कि बॉडी को आप रोज न्यूट्रिएंट्स प्रोवाइड कर रहे हो जो जाके एक्चुअली हीलिंग के काम में आएंगे बॉडी के अंदर. तो उस केस में इंजर्ड टिश्यू और हमको जो मसल्स का एट्रोफी है एंड हमको सपोर्ट करना है, स्ट्रेंथ प्रिवेंशन प्रिजर्वेशन करना है. जब हम रिहैब में है, हमारा मेन काम है कि जो हमारी स्ट्रेंथ है, ऑफ कोर्स कुछ हद तक कुछ परसेंट स्ट्रेंथ आपकी कम होनी है रिहैब के टाइम में, बिकॉज आपकी वो पर्टिकुलर मसल्स उतना यूज नहीं हो रहा है, उतना एवरीडे ट्रेन नहीं हो रहा है. लेकिन हमारा एम ये होना चाहिए कि हम जितना प्रिजर्व कर सके उसका स्ट्रेंथ. आपका 15-20%, 30% स्ट्रेंथ कम हुआ है, वी विल ट्राई टू कीप इट टू दैट. वी हैव टू मेक श्योर कि हम उससे ज्यादा डाउन ना होने दे मसल्स का स्ट्रेंथ. इसलिए ये चीज जरूरी है आपको अपने न्यूट्रिशन पे ध्यान देना, क्योंकि बाहर से हम कुछ बैंडेज या कुछ ऑइंटमेंट लगा के मसल का स्ट्रेंथ नहीं बढ़ा पाएंगे। उसके लिए आप बॉडी के अंदर क्या डाल रहे हो, आप क्या खा रहे हो, दैट मेक्स मोर impact there. So level, another thing is when your body is injured, तब आपका ऑक्सीडेटिव स्ट्रेस बहुत होता है, फ्री रेडिकल्स बहुत होते हैं। तो उस टाइम पे बिकॉज ऑफ स्ट्रेस आपके बॉडी में विटामिन सी लेवल कम होने लगता है, बिकॉज आपका बॉडी विटामिन सी जो है उसको स्टोर करके नहीं रखता है। सो दैट्स व्हाई वी हैव टू मेक श्योर दैट विटामिन सी intake is increased during your rehab. Then vitamin A, which is again another antioxidant, ये सेल को सेल की ग्रोथ में, डेवलपमेंट में हेल्प करता है। तो आपका जो भी इंजरी हुआ है, मसल इंजरी है, उसमें टिश्यूज जो इंजर्ड होते हैं, उनका ग्रोथ और डेवलपमेंट के लिए विटामिन ए का होना भी जरूरी होता है आपकी डाइट के अंदर ड्यूरिंग रिहैब. And again, vitamin E, as I already said, this helps with inflammation. It inhibits the inflammation. तो ये तीन हैं और ये तीनों ही विटामिन एंटीऑक्सीडेंट हैं। तो इसलिए जरूरी है कि ये हमारे डाइट के अंदर रिहैब के टाइम पे हम ध्यान दें कि आपके डाइट के अंदर होना चाहिए. जिंक एंड आयरन आर ऑल्सो इम्पॉर्टेंट फॉर वुंड हीलिंग. So these two are also important. I'm talking about micronutrients. Generally हम लोग मिस आउट कर देते हैं. मैक्रो का हम ध्यान देते हैं कि अच्छा हमको थोड़ा प्रोटीन भी खाना है, कार्बोहाइड्रेट भी, बट माइक्रोज को हम जनरली मिस आउट कर देते हैं. In case your body has a tendency to be on a lower hemoglobin, आपका hemoglobin अगर कम रहता है तो हम सजेस्ट करते हैं कि डायरेक्टली डाइट काम नहीं करेगी. You have to take a supplement. You have to take either a syrup or you have to take a tablet. क्योंकि डाइट धीरे धीरे बढ़ाएगा आपका जो हीमोग्लोबिन लेवल है, या आपके बॉडी में अगर आयरन की कमी है तो वी मेक श्योर कि उस टाइम पे आपको इमीडिएटली सप्लीमेंट, स्पेशली अगर आप इंजर्ड हो उस टाइम पे इट्स मोर इम्पॉर्टेंट दैट यू स्टार्ट टेकिंग द सप्लीमेंट राइट अवे टू मेक श्योर दैट योर बॉडी इज नॉट लैकिंग इन ऑल दोज माइक्रोन्यूट्रिएंट्स. Again, I come back to hydration, because generally athletes relate their hydration requirement to the training. Now they think we are not training, we don't need to drink too much water. So I can give you examples, few athletes who during training, they were drinking 4 to 5 liters of water. During rehab, their water intake came to 1 to 2 liters, which is dangerous level, because उनको और आके बोलते हैं मैडम पसीना तो निकल नहीं रहा, फिर इतना पानी क्यों पिए हम. But the thing is, your muscles, your body, your muscles need to be healthy. Your muscles need water. Your brain needs water to function properly. आपका पूरा बहुत सारा body का जो physiological system है, that gets affected if you are not hydrated well. तो इसलिए hydration is really, really important during rehab also. Having said that, अगर during training, if somebody is drinking say 4 liters of water, now during rehab, if you bring it down to say 2.5 to 3 liters, because I understand there are no sweat losses happening there. So if you bring it down to 2.5 to 3 liters, that should suffice. But if you bring it down to 1 to 2 liters, that is pathetic. वो आपके healing को delay करेगा. That's why it is required to pay attention to hydration also at the time of rehab. Then nutrition recovery roadmap. ये जनरली जो न्यूट्रिशन के थ्रू आपका जब रिकवरी हो रहा है उस टाइम पे न्यूट्रिशन में आपको क्या क्या चीज ध्यान रखना है. फर्स्ट थिंग इज लॉन्ग टर्म रिकवरी मे रिक्वायर अ रिड्यूस कैलोरी इनटेक. जनरली इफ इट्स अ माइनर इंजरी, आप केवल 1 या 2 दिन के लिए रिहैब में और मे बी 2-3 डेज के लिए, एंड देन अगेन यू आर गोइंग बैक टू ट्रेनिंग. देन कैलोरी इनटेक आपको कम नहीं करना है. देन रेगुलर आप अपना खाना खाते रहिए, वॉट एवर यू आर ईटिंग अर्लियर, because उस time पे if we reduce it for a couple of days, but I know that the third day you have to go back to the training, that time your body may be deprived of those calories. So इसलिए अगर long term recovery है आपका, if it is lasting more than 7 days, आपका जो recovery का process है, say after a surgery you have to be long time on the recovery path, तो उस time पे and generally we take अगर 6 से 7 दिन से ज्यादा आप rest कर रहे हो, then you need to make sure that you reduce the calorie intake. This is the first thing that many athletes do not look into, and then they come back with a totally different body composition, which is not right for their sport. Next point here, surgical trauma, fever or infection may require major dietary changes. So if and when I talk about fever, it's not just sometimes, you know, due to extra exertion and all that you get a fever overnight, but next few days then you're fine. When we talk about this fever, there are anyways, you know, lots of diseases going on and all. So if your fever lasts more than 2 or 3 days, आपको ऐसा मलेरिया है, यू नो, टाइफॉइड है, एनी अदर काइंड ऑफ जो आपका बॉडी का एनर्जी को ड्रेन आउट करता है, या कोई सर्जिकल ट्रॉमा है, आप आफ्टर सर्जरी इफ यू आर देयर इन रिकवरी, और इफ देयर इज अ इन्फेक्शन विच विल टेक अ लॉन्गर टाइम टू हील, उस केस में आपको डाइटरी चेंजेस, मेजर डाइटरी चेंजेस करने पड़ते हैं in terms of macronutrients also and in terms of micronutrients also. किसी उसमें आपको कार्बोहाइड्रेट का इंटेक बढ़ाना पड़ेगा क्योंकि आपके बॉडी को ज्यादा जरूरत है. अगर आपको फीवर विद चिल्स आ रहा है, आपको स्वेट आउट भी हो रहा है, वो सारी चीजें, तो आपको वाटर इंटेक आपका बढ़ाना पड़ेगा. तो उस सब केस में आपको अपना डाइटरी, मेजर डाइटरी चेंजेस करना पड़ेगा. Then focus on nutrient dense food that provide important micronutrients. This is something very important, nutrient dense food. When we talk about nutrient dense food, I can give you example of simply almonds or walnuts, which are very small but are full of nutrients. It will give you good fatty acids, it will give you minerals and vitamins also. तो छोटा सा थोड़ा सा पोर्शन खाने पे भी आपको न्यूट्रिशन बहुत अच्छा मिल रहा है, वर्सेस अ कैंडी. आपको कैंडी से सेटिस्फेक्शन मिलेगा बट न्यूट्रिशन नहीं मिल रहा है. दैट्स व्हाई वी टॉक अबाउट न्यूट्रिएंट डेंस फूड, कि थोड़ा क्वांटिटी खाने पे भी आपको न्यूट्रिशन. Say, take example of apple. So apple is a nutrient dense food. You get good carbohydrates there, you get fibers there, and you also get vitamins and minerals. So that's why that is a nutrient dense food. So that's why during your recovery, you need to make sure that you are taking more of the nutrient dense food rather than इंक्रीजिंग द क्वांटिटी ऑफ फूड. जनरली क्या होता है, लोग फ्रूट वगैरह खाना, राइस ज्यादा खाने लग रहे हैं, या चपाती बढ़ा दी कि अभी हमको बाकी सब चीजों का जरूरत नहीं है, हम सप्लीमेंट भी नहीं ले रहे हैं, तो लेट अस ईट मोर ऑफ दिस. एंड लेट मी टेल यू, many of the athletes come back with a weight gain. Reason being, energy balance is not there. They are eating but they are not burning those calories. So as long as you're training every day, then whatever you're eating and then you're burning those calories will build an equilibrium. So there will be a balance. But when you're in rehab, you can't keep eating like what you were doing earlier before going into rehab, because utna calorie body ke andar aayega, whatever is surplus will be converted to fat, and then when you go back to the training, aap already deconditioned ho, because aapka body ka fat gain zyada ho gaya hai. So you need to work extra to lose that fat, and then you can. So nutritionally, my aim always is to, whenever my athlete goes back to the training, the regular training, he or she should not struggle a lot to get that energy. We want them to start training nicely as prescribed by their doctors and the coaches. वो पूरा ये team work होता है. But we don't want them to totally run out of energy, and we also don't want them to go there with lots of fat gained. So that's why it is important to know the quantities or where you need to reduce. So when it comes to, see, just simply eating rice and chapati, कई बार क्या होता है, boredom में भी खाने लगते हैं athletes. I'll discuss that in the next slide. Maintain adequate protein intake, because especially if we don't want the muscles to go weak by the time you come out of your rehab. If your protein intake was not enough, your muscles will not be in a very healthy shape. तो इसलिए what I have written, adequate protein intake. I have not written that increase the protein intake, because it depends on kind of injuries. If there is a major surgery, if there is a, major muscle injury, and there was a long time rehab, in that case we may need to increase the protein intake. But in general, we want to maintain the protein intake, the adequate protein intake, so that your body is not lacking in that macronutrient. Avoid emotional overeating. That is something very common during rehabilitation, because the athlete is under emotional stress, that he or she is not able to go for training, or because that's their life. Those who are into training morning and evening, that's their life, and it's the bigger part of their life is put on the bed for rest. So then what happens, sometimes they connect more with food, either to kill the boredom or to take out that, to handle the emotional stress. So that is something we need to work with the athletes, and again as a team, the doctors, the physios, the psychologists and nutritionists, all, even the support staff, the coaches and all, to make sure that their athlete is eating healthy even during the recovery phase when they are into rehab, because that will play a major role when they come back to the proper training. Now, what should be avoided during the rehab? First, any type of nutrient deficiency. We encourage our athlete to eat a balanced diet so that we make sure that their body is getting enough nutrients. We don't encourage them to survive too much on protein during the rehab, because as long as their digestive system is not affected, their body is going to take care of getting the nutrients, digesting and absorbing it for their own functions. Then we also need to avoid energy surplus, that extra energy. As I said, that extra energy will be no matter where, if it's coming from fat, protein or carbohydrate, anything extra will be deposited in body as fat. We don't want to do that, because just for example, if my athlete is supposed to have 12% of fat for certain sport, and during rehab he or she does not control the fat or the energy, then that extra energy will be converted to fat. By the time he goes to the training, uska fat percent 18-19 हो गया. तो my first thing will be कि इसको पहले fat percent कम करना है to train optimally. So that's why we tell avoid energy surplus. Processed food is something, with my experience now working 10 years in India, is that generally they grab a pack of chips, or especially it happens in the residential academies जहाँ पे बच्चे train कर रहे हैं, even elite athletes, कि रूम में बैठ के बोर हो रहे हैं तो दोस्तों से चिप्स मंगा लिया, बिस्किट्स मंगा लिया, एंड वो खाते जा रहे हैं. So they start treating food as entertainment, which is not the case. आपका इमोशनल स्ट्रेस को फाइट करने के लिए फूड को यूज नहीं करना है. Then another point here is alcohol. तो ये रिहैब के टाइम पे डेफिनेटली अवॉइड करना है. आई हैव सीन कपल ऑफ एथलीट्स, सीनियर एथलीट्स, जो जब रिहैब में थे उनको किसी ने बोला कि आप अगर बियर थोड़ा बढ़ा दोगे तो आपका इंजरी जल्दी हील हो जाएगा. So we have that kind of cases also, but alcohol is not going to heal you. Alcohol actually delays the recovery. It actually delays your injury healing. So please don't fall for certain expert advice that alcohol agar aap piyoge to it's going to help you. And next point there is emotional stress, which I already mentioned, and especially I see this more in India. If I compare my experience US में जो clients थे versus India में जो athletes clients हैं, कि यहाँ पे हम लोग ओवरऑल एनीवेज हम फूड के साथ बहुत इमोशनली कनेक्टेड हैं. गुस्सा है तो खाना नहीं खाना है, या गुस्से में है तो ज्यादा खा लेंगे, दैट वेज, या बहुत हैप्पी है तो जाके ट्रीट लेना है या पार्टी करना है, वो सारी हम इमोशनली बहुत कनेक्टेड हैं फूड के साथ में. एंड व्हेन देयर इज अनदर इमोशनल स्ट्रेस इन टर्म्स ऑफ इंजरी और रिहैबिलिटेशन, वेयर यू आर अवे फ्रॉम व्हाट यू लव, बिकॉज स्पोर्ट्स ट्रेनिंग इज समथिंग यू रियली लव, दैट्स व्हाई यू आर इन द स्पोर्ट्स. सो व्हेन यू आर पुट अवे फ्रॉम दैट, you are under a emotional stress. So emotional stress is something the athletes and the support staff need to work on in order to avoid unusual eating patterns. Now, a few common mistakes that athletes do during their rehabilitation, and I have examples for all these points. जितने भी rehab में athletes के साथ मैंने काम किया है. One is they start skipping meals. It's those athletes who are actually into weight category sports or aesthetic sports. उनको ये डर लगा रहता है कि हमारा weight बढ़ जाएगा, and they start skipping meals. What they have to do is reduce the portion size in each meal. आपका breakfast, lunch and dinner थोड़ा थोड़ा quantity कम कर दीजिए, but please do not skip the meals, because first you're depriving your body for a longer period of time from food. Second, when you go back to training, you will have energy deficiencies, which we do not want the athletes to have. Second mistake, which they usually do, is poor food choices. As I already said, that bore ho rahe hain to biscuits खा लिया, chips खा लिया, and that is very common. And biscuits भी खाएंगे तो वो cream वाला biscuit or Good Day, which is even worse. So please make sure poor food choices can lead to altered body composition. It can, even if it does not contain nutrients, it can delay your injury healing. So that's why don't make this mistake if someone is into rehab. Next point here is inadequate fluid replacement. So again, this I already explained that generally they make mistake, they reduce their water intake a lot. So in that case, their body will be dehydrated, and that will again delay their rehabilitation. That will delay, extend the rehabilitation period. So hydration is something that we need to work on during rehab also. Next is irregular and emotional eating. I'll just give you example of a boxer. He got injured and was asked to, he had shoulder injury, and he went for surgery and was asked to be away from his field. So he, for some time, he went home, came back to the institute, and again started his rehabilitation. And he had still about a month and a half to go till he get back to, return to sport. One day I was asking that how come, I don't see any reduction in your weight now when you go back to, and when I took the diet diet history of this person, he wasn't eating anything wrong, but what he was doing is those recovery drinks which are very high in sugar. So what this guy was doing, he was getting bored, so he will mix that and वो शरबत के जैसे, he was drinking it कि मैडम वो मन नहीं लग रहा था या टीवी देख रहा था तो मैंने वो घोल के. So he was actually drinking that recovery drink which is very high in sugar. Your body can manage that sugar when you are into proper sports training, but when you're not training, you do not need that. So please, that is something. Irregular eating and then emotional. He said पहले था ट्रेनिंग में तो ये पीता था पूरे टाइम, अभी मैंने वो पीना चालू कर दिया, बट मैं कुछ भी खा नहीं रहा हूँ एक्स्ट्रा. So this is something, as a nutritionist, I sit with my athletes, I visit them even wherever they are rehabilitating, and I check with them what exactly they are eating. But there are minute points also we need to see, that this person was drinking enough fluid, but this fluid contained lots of sugar. So those things also we need to look into, because that's a mistake that athletes can make during rehab. Now, the last point here is failing to cut down the calories during injury and non-training phase. So again, as I already said, that if you have energy surplus, that is going to make you increase weight because you're not burning those calories. So if you know that your rehab process is, your rehab time is going to be more than 5-6 days, then you need to cut down on your total calorie intake. And major cut down we take from the fat containing food, and rest we decide which food we need to cut down depending on the type of injury. So these are few mistakes that generally our athletes make, and I have covered things in a very normal terms, बहुत ही easy ताकि सबको समझ में आ सके. बहुत ज़्यादा papers वगैरह का यहाँ पे मैंने ये year में ये publish हुआ वो सब नहीं use किया, because उसमें से जो भी extracts थे that I tried to put on my slides. So now if you have any questions, please feel free to ask.
Thank you, Madam Aradhana Sharma ji. किसी का अगर कोई सवाल है तो you can really ask.
Good afternoon, ma'am.
Good afternoon.
Ma'am, Anu here.
Hello, Anu.
Ma'am, I just have a question. I have an athlete. She's a cricket player, and she's just 23 years old. And because of her ill health, means उसकी diet and all, वो ठीक नहीं है. Training part is very nice. She is scoring very well. She is on ground. She is excellent on ground. But उसकी diet के कारण उसकी selections नहीं हो पा रही है. Last 2 years, मतलब last 1 year से. Last year जो trials हुए उसमें भी नहीं हुए और इस बार भी नहीं हुए. तो एक आप मुझे क्या,
वन थिंग आई वांट टू नो कि आप कह रहे हो बहुत अच्छा खेल रहे हैं, तो सिलेक्शन के लिए क्राइटेरिया तो खेलना होगा. दे वोंट केयर कि डाइट क्या ले रहे हैं. ऑफ कोर्स फॉर डाइट यू नीड टू कंसल्ट अ स्पोर्ट्स न्यूट्रिशनिस्ट जो उनका ना एनर्जी बैलेंस बता सकेगा आपको. यू नो दैट
शी इज रियली थिन. उसकी एक्चुअल फिटनेस नहीं है बिल्कुल भी. तो फिटनेस की वजह से जो वो थक जाती है जल्दी, तो उसकी वजह से उसमें सिलेक्शन नहीं हो पा रहा है. तो आई जस्ट वांट टू नो कि उसको क्या डाइट दी जाए जिससे कि थोड़ा उसको बॉडी ग्रो करे. She is not having, मतलब स्ट्रेंथ नहीं है बिल्कुल भी.
Okay, so see, I actually need to look into what she exactly is eating right now. Based on that, I will see उसका बढ़ाना क्या है. But in general, अगर बहुत जल्दी थक जा रही है तो first thing you need to look into उसका hydration. अगर पानी कम पी रही है या फिर ट्रेनिंग के टाइम पे इलेक्ट्रोलाइट इम्बैलेंस हो रहा है, उसके कारण थकान सबसे जल्दी आती है. एंड ओवरऑल प्रोटीन इनटेक उनके डाइट में आप देखो. एंड वेन एवर शी गोज फॉर ट्रेनिंग, मेक श्योर शी टेक समथिंग दैट कंटेन्स कार्बोहाइड्रेट. नहीं तो एनर्जी बहुत जल्दी ड्रेन होता है. तो ट्रेनिंग पे जाने के पहले इवन इफ इट्स अ बनाना और एप्पल या कुछ एक सैंडविच खा के चले गए, वो जरूरी है, क्योंकि खाली पेट ट्रेनिंग ठीक नहीं है. And then second is they need to make sure that water intake is good. Now based on her diet only one can tell कि वो already क्या खा रही है, क्या कमी है, उसको क्या बढ़ाना चाहिए. वो ऐसे generally I won't be able to tell.
Yeah, absolutely correct. One has to take all the pre-tests. And if you
Sorry,
ask
sir?
me a big question, actually it is a big question. कि ऐसे कैसे होगा? It's really difficult for anyone to really reply that unless until it is a case study. Any more question?
Okay.
Sir, can I just join in?
Yeah, welcome.
Okay, ma'am, it was a very good talk and बहुत अच्छा था. मैं क्वेश्चन नहीं है मेरा, बट जो मैम ने एक चीज बताया कि जब ये रिहैब करते हैं और जब ये स्पेशली जब इतना एक्टिविटी नहीं होते, सो वी हैव टू बी वेरी केयरफुल विद द डाइट. तो वो मैं सबको रिपीट कर रहा हूँ जो मैम ने कहा है, बिकॉज यू नो आई एम टेकिंग केयर ऑफ अराउंड 40 टीम्स एंड मुझे सबसे ज्यादा प्रॉब्लम सब में होता है. बट जो वेट कैटेगरी स्पोर्ट्स होते हैं, तो आप उसको रिहैब कर रहे हो और ये खाए जा रहा है, ट्रेनिंग इतनी नहीं हो रही है, एंड पता चला वो 65 केजी का बंदा है या लड़की 55 केजी की है, और अब जब तक वो रिहैब से निकले स्ट्रॉन्ग, बट शी और ही इज लाइक 10 केजी 7 केजीज ओवरवेट. सो मैम वाले जो बहुत शी रिएटरेटेड 2-3 टाइम्स कि उनका रिहैबिलिटेशन के टाइम में यू हैव टू एंश्योर एंड कंट्रोल द फूड आल्सो, बिकॉज व्हाट हैज हैपेंड इज रिहैब करते हैं, 10 किलो ओवरवेट है, जैसे ठीक हो गया, पता चला धूप और गर्मी में आप रेनकोट पहन के रबर शीट्स पहन के रनिंग कर रहे हैं, एंड दैट इज बेसिकली फ्लूइड लॉस, and they are looking in for surgery. They are looking in for surgery definitely.
Exactly.
दूसरा चीज मैम ने एक और बात बोला कि when they come for rehabilitation they don't drink water. मेरा एक्सपीरियंस में बता दूं, if you can give me 1 minute, I'll just tell you. मैं तो क्योंकि I also coincidentally being in forces, you know, I have a थोड़ी सी पावर रहती है being in a senior rank. मैं भगा देता हूँ. मैं ग्राउंड में बगैर पानी की बोतल किसी को घुसने नहीं देता हूँ, और हर प्लेयर को मैंने बोला चाहे सरकारी से खरीदो, चाहे अपना अच्छा वाटर बॉटल खरीदो, उसमें लेबल कीजिए, अपना नाम लीजिए. कोविड के टाइम पे आई टेल देम एग्जैक्टली नो शेयरिंग, एंड हाइड्रेशन इज सो इम्पोर्टेंट, बिकॉज व्हाट हैपेंस इज कि, और आई एम मैम की तरफ से आई एग्री विथ हर, बट आई एम जस्ट एडिंग टू दिस हाइड्रेशन का. इवन इफ दे आर कमिंग फॉर अ लेक्चर, अ टॉक, आई एम टॉकिंग ऑन एंटी डोपिंग, I will not start the lecture till each and every person is carrying his water bottle. I will not start the classes. I will not allow them to come inside the center without the water bottle, individual water bottle. तो कहता है सर हम 2 लीटर ले गए 2 प्लेयर. I said कोविड का टाइम में नो बॉटल शेयरिंग, नंबर 1. और आपको दूसरी चीज प्लेयर्स का जो एजुकेशन का बताऊंगा, मैं अपना एक एक्सपीरियंस शेयर करूंगा. When I just finished sports medicine, I joined my CRPF hockey team. We went to play. So now I was, जब नया ज्वाइन करते हैं पूरी जोश में होता है, and I spoke to a couple of people. मैंने अपने पैसे भी खर्च किए, मैं फ्लाइट से, आजकल तो एक्स्ट्रा बैगेज अलाउ नहीं करते, मैंने इलेक्ट्रोलाइट, स्पोर्ट्स ड्रिंक्स सारा लेके, यू नो, फर्स्ट 2-3 डेज मैंने पानी की बोतल सबको भराया, बनवाया, यू नो, जैसे आई सॉ इन द हॉकी वर्ल्ड कप कैसे पीपल डू इट, हाउ द फिजियोस डू इट. तो वो चीज मैंने इनके साथ इंप्लीमेंट किया. तीसरा दिन तक देखता बोतल सारे खाली पड़ा है, एंड दे वर एक्सपेक्टिंग मी द डॉक्टर टू फिल द वाटर फॉर देम. ओके, सो ये क्या होता है कि इनको आपको बार बार यू टू हैमर इट इन देयर हेड्स कि यू नीड टू कैरी योर वाटर, यू नीड टू कैरी एक्स्ट्रा वाटर. पानी नहीं होगा तो नहीं पिएंगे, इरेस्पेक्टिव ऑफ द स्पोर्ट. सो ये 3-4 चीजें आई रियली एग्री विद मैम, एंड आई फील दैट एवरीबडी नोज, इट्स जस्ट दैट कि वी हैव टू इम्प्लीमेंट इट, वो हमको ही करना पड़ेगा. सो दैट इज द थिंग आई ऐड. मैम, थैंक यू सो मच फॉर वंडरफुल टॉक, मैम.
Thank you, sir. I think we are having another couple of speakers. It is already 1:50. So if you people please permit me to really take up the another 2 speaker, that will be good. And thank you, Madam Aradhana.
Thank you, pleasure.
Yeah, because after the scheduled deliberation, we can have some discussion. I think Dr. Vikram will agree with me. So if I am permitted, may I request Dr. Akshat Pandey. Dr. Akshat Pandey will be speaking on sports injuries in boxing. To his credit, he is a consultant advisor for Rajasthan Police Headquarters, then Faculty Sports Science, Gayos Fitness Mumbai, the speaker and mentor for COVID-19 MHRD projects, Physio, CWG 2010-2014, Asian Games 2014, and London 2012. Editorial board member for the national and the international journals. I think he is doing an excellent job. Submitted a research project in IIT Kanpur, then awarded Outstanding Professional Excellence Award by SGBS University. So may I request Dr. Akshat Pandey to please take the floor. Please make sure that others, those who are participants, please mute your mic as well as your mic. Mic and your video, both. Akshat Pandey, if you are listening, please.
Voice is audible to all, sir.
Yeah, yes, perfect. Make
So
it.
should I start, sir? Should I start with your permission, please?
Yeah. Just make it full screen in presentation mode.
Is it okay?
Not in the full screen. Yeah, you can start.
Akshat, your video is not visible, so just put on your camera.
Sir, there is an issue with the camera. I am not able to.
Okay, fine. You go ahead and you can start the slideshow the way you want. Thank you.
Okay, done. I think there's a technical issue which is coming with the camera, so I cannot help with that part.
Okay, fine. You go ahead.
Sir, the title of my talk is the official criteria of the intake of boxers. It is a review study which I did it at Sports Authority of India, National Boxing Academy, Rohtak. I'm starting it, sir.
Yes, Akshat, please go ahead.
We started with a call to revise the intake age of the boxers because with reference to my experience, we had seen it, sir, the senior team in the boxing, the youth team in the boxing, the sub-junior team into the boxing. There are basically different categories of the boxers who play for Team India, maybe it a youth, sub-junior, and there is a specific age classification which are going on. So we have taken up a study in which we have seen to use the sustain the impact of trauma, particularly into the epitaxis patterns of the injury, which I have taken up a call. The subject of the study was the official criteria of the intake of boxers in their specific age categories, with the sole motto of allowing the player to better sustain the impact of trauma while playing in the I feel that if this study is scientifically proven, can act as a revolution in various sports, specifically maybe into the combat sports by benefiting the players of better absorptions of impact of trauma. The research synopsis lies to the fact that in which there is a proposal to work on the official criteria of the intake of boxers in their specific age groups, youth and the junior. Taking into the consideration the pattern of anterior nasal rupture bleeds, which are common in the youth and the junior as compared to the seniors. This was the observation which I did into my Sports Authority of India and National Boxing Academy tenure. And that was the base point of my research study which I did it. A proposal called to revise the intake age of the boxers on a +1 to 2 years from their mean average age, the skeletal age.
Akshat.
Yes, sir.
I think we have decided that you would be talking something about general for the boxing injuries. So you're narrating your research on this. So, so I don't know how this is going to help the attendees, because we are here to learn about the boxing injuries as a whole, because they're mostly the sports teacher and the coaches. So not too much into the research.
Okay.
So do you have anything related to directly about the boxing injuries? That's what is
Sir,
expected.
I think so. The paper which I had submitted to you is all about the research and the basic boxing injuries.
Sorry?
Sir, I think the paper which I had submitted to you on the
Hmm.
PPT is all about 75% related to the research and 25% is on the boxing injuries management.
Okay, so can you please, because I think they'll not be interested too much in the research work. So,
I think, sir, there might be some.
okay, fine. Okay, fine. You go ahead. Okay, yeah.
I mean, sir, I cannot.
Okay,
help at
okay,
the very
you.
last moment, sir.
Okay, you go ahead. Fine.
So basically, there are three types of the skeletons which we have studied. Number one is into the underdeveloped skeleton, age to neonatal to 10 to 12 years of age. Second is the developing skeleton, 9 years above till to 15 to 16, and developed skeleton is greater than 18 to 19. Now, in this, a few reasons for the early exposure to the sports, maybe the overweight of the kids, overeating, lethargies in doing self-work, health issues, family pressure bhi ho sakta tha. This category falls under developed skeletons category, and the probability of getting more injuries in early childhood lies with the more. So the category 2, this category of sports exposures are better in terms of the skeletal developments, and their ability to sustain trauma is better by all means. The exposure in this category purely depends upon the regional facilities of the sports availability, the parents' knowledge, the scientific education, backup system, and monitoring of the progress. So this is the class 3 category. In this, the sports players holds the best ability to sustain trauma in any means, be it ENT or the soft tissues, abdominal. The advantage of this category is that the skeletal system is mature and better act as a shock absorber than underdeveloped or a developing skeleton. So there are basically 10 criteria which was taken care of while performing this research at National Boxing Academy. The game was the boxing, the gender was the male versus female, age specifically filled up by the player, category youth, junior or senior, years of experience in the boxing was filled up by the boxer, history of nasal injuries to be filled up by the boxer, and the details to be provided by the boxer itself. Medical management if consulted to be filled up by the boxer, outcomes if any reported, progression or reduction to be reported by the player itself, ENT referrals if any reported by the boxer, and investigations and the follow-ups to be provided by the player itself. So once we are going with the findings, basically there were two systems which were going on. The first is the residential versus the non-residential players. In the residentials, we had the hostel players, and the non-residentials, we had a common play scheme in which the players of 8 years of age, irrespective of the sex concerned, are into the boxing on the day-to-day basis. These two categories were compared, and a gross study was done. The forms were filled by the common play players on the random basis, and what we come to know by the detail provided is that every second boxer in common play scheme is having the problem of ENT bleed, which is on the minimum side or on the lesser side in senior boxers or the residential boxers. The total number of the players consulted in National Boxing Academy was 50. The male dominate the females. Total number of players consulted in common play scheme is 50. Standard player data liya tha sir hum logon ne. The male is greater than the female. The problems of ENT bleed history reported by the residential trainees is 4 out of 5 out of 50, approximately 10%. Problems of ENT bleed history reported by common play scheme is 35 to 50, approximately 70%. Few senior trainees still have the ENT history of the bleeds, that is 1 to 2 out of 50. And the majority of common play scheme trainees reported such incidences. Now we have senior, those who have reported to the ENT doctors, only 1% of the total documented case was reported. Youth and sub-junior common play scheme, 2 to 3% of the total documented cases reported. Few cases reported, citing the personal and the social reasons such as the money investigation and the wasting of the time in this process as per their thinking. And few cases were conservatively managed. So what did the observation say is all about? We observed that there are basically following factors responsible if the underdeveloped and the premature skeletons of the boxers exposed to the boxing in their younger age and their lesser ability to sustain trauma, resulting which there are more cases of ENT bleeds when compared to the residential players with developed skeletons and with the better ability. The rest of the soft tissue injuries, fractures, and punching injuries remain common in both categories with the unique variations in their healing process depending upon their metabolism, body structure, and the diet. More specific boxing experience, which ranges from few months, years in commonplace scheme to good amount of years in the seniors. Few seniors residential academy have reported initial history of the nasal bleed, which was either medically consulted or was not done, citing the personal reasons. 1 and 2 boxers still present with a positive history, the local factors, family pressure, early exposures to the sports, the lack of scientific backup in terms of providing update information, and good opportunities of getting jobs in the sports. Now let us go with how do we classify the sports injuries. Injuries may be divided into according to the cause of the injury or the pattern in which it is caused, maybe the direct injuries or the indirect injuries. Other classifications can be used, such as the type of tissues damaged in the injuries, such as the hard tissue and the soft tissues. Injuries may be classified, maybe the direct injuries, which according to the cause of the injury or the pattern in which it is caused. And other classifications can be used, such as the types of tissues damaged into the injuries. They may be classified into the hard tissues or the soft tissues. Into the indirect injuries, they are caused by the internal or the external forces and usually results in an injury occurring at a site away from the initial force. Can occur as a result of a poor preparation or excessive movement. Can occur because of an undue strain on muscles, tendons, or ligaments and cause irritation and possible structure damage. Examples include the footballer, basketball players tears ligaments from twisting, hamstring strains while performing the in and particular athletic event. The soft tissues may be the muscle, tendons, ligaments, joint tissues, fatty tissues. Any injuries to these are classified as the soft tissue injuries. And the hard tissues may be the teeth and the bones and the skeletal parts included. It may be the bruises, sprains, strains, laceration, dislocations, and tendonitis, which may fall into the soft tissue injuries. Overuse maybe by the repetitive low impact exercises such as the jogging or the swimming. The cause included poor training techniques, high intensity too soon poor surfaces, inappropriate equipment and physical characteristics. Injuries characterized by the pain and the inflammation. The common overuse injuries include the shin tendonitis, stress fractures, or commonly known as the repetitive strain injuries. How do we go with an protocol with an injury or the illness occurs? We go with the doctor ABCD, it's already been described, and TOTAPS. In this, we talk to the patient. Removal from the field of the play. It is more like do not attempt to remove a player from the field who is an unconscious, has a suspected spinal injury. Always think before intervention, has a major dislocation or the fracture, has a suspected internal injury, has an injury or condition that could be seriously worsened by the movement. How do we manage with the sequence of sports injury prevention? We can go with establish the extent of the injury, the incidence, connected to establish the etiology and mechanism of the injury. Number 3, introduce preventive measures. And number 4, assess its effectiveness by repeating step 1. What are the factors which may affect the injuries? They may be the intrinsic factors, modifiable or the non-modifiable factors. And the extraneous factors are not inherent to the athlete. The non-modified factors may be the age, gender, ethnicity, and the genetics. They cannot be changed at any cost. They are uniform respective to the player. The modifiable factors may be the muscle strength and the power, which may be changed. Flexibility, yes, it may change according to the age, body weight, and the height of the player. The skill level, it depends upon the game in which the player is involved. And the health, the history of the previous injury and the joint instability. Cutting short to the conclusion part, it's my proposal that it should not there be a age-specific criteria for intake of boxers in their youth with variations of 1 + 1 to +2 years of age from their mean average age of body development, taking into consideration the pattern of developed skeleton and developing skeleton and their individual ability to sustain trauma in particular boxing. See, what are the benefits which have been proposed in this study is that if we be able to correlate the relationship between the developing skeleton and the developed skeleton with their individual ability to sustain trauma, then we can be able to revise the intake age of the youth boxers. If this happened, then the boxers who are coming into boxing will be able to better sustain the impact of trauma, especially nosebleeds, and the pattern of healing of injuries will be on the better side, irrespective of its nature concerned. In general, the human practice, irrespective of the geographical and social factors concerned, the parents should understand that every game has its own individualities and that should be respected by all means. The intake age of combat sports in India should be revised by taking the mean actual age of the skeletal development with maximum variations, and permitted should be 1 or 2 years as per the findings of this research synopsis.
So thank you, Akshat, for sharing this. And
So there might be a confusion. I mean, initially there might be certain doubts or something, but I think it was what I had prepared for.
okay, fine. Yeah. So Akshat, please stop sharing your screen.
Okay.
Yeah. Do we have Dr. Aradhana still with us? Dr. Aradhana, are you still with us?
Yeah, she's there.
Yes, I'm here. Sorry,
Yeah.
I'm muted.
Yeah. So Aradhana ji, there's a question for you from Hafiz from Pakistan. Hafiz is with archery. So I think question is very long, but if you want to take this, in competition, which type of food substitute for quick energy and recovery in eating and drinking? So in archery, just a quick tip if you want to give.
So this is for during competition, and is he asking only archery relevant or?
Yeah, archery relevant. Yeah.
Okay, so for archery, say you can take in terms of having solid food, we generally tell people not during competition, we tell them not to have it. But in archery, since there is not too much of movement, right? And they have to be in one place, we generally tell them to have a fruit, which their body is used to. If they were having some kind of fruit during their earlier trainings, then they can continue with that. Only caution here is don't try anything new during the competition. Second thing is, if it's depending on what kind of climate they are competing in, if it's say very tropical region, or if it's like very hot and humid, the main concern there is to replenish their electrolyte losses. Though even if it's not too much of physical workout there, they may not be sweating a lot, but they may be losing the electrolytes. And in a game like archery, mental focus is really, really important. Mental alertness is really important. So they need to pay more attention on their hydration and the electrolytes. So generally, I tell them to have an isotonic drink, and very basic, which has a combination of different kind of sugars, as well as sodium content and potassium content. And of course, sodium chloride, that has to be in form of salt. So if they take it during they keep sipping on it during their whole competition, that is going to help. During the break, when the other team is shooting and all, a few bites of a fruit should help. A few of my archers, the archers that I have worked with, few of the archers, they like to have dry fruits. Now, I'm not telling dry nuts. Fruits is say dates, or it can be dry raisins or figs and stuff like that. So if fresh fruit is not the option, they can always carry these dry fruits. But first priority is to replenish energy and the electrolyte losses that you take care of with a good hydration drink or the recovery drink, whichever name it is available in.
Thank you.
Okay. Thank you. So Subhiji, you can take Vaibhav.
To appease, I think the drinking, when you say about the drinking, just to add on with the madam, I believe because I am also working with the archery, you must take care that they are not asking for the water. Before that, you should really replenish it. That will be the best answer, right? If somebody is asking for water, it means already he or she is dehydrated. So thank you, madam. Thank you, Dr. Vikram. Now we have our last speaker, Dr. Vaibhav Daga, who is the head of the Department of Rehabilitation in Kokilaben Hospital, Mumbai, who is having a long association even with me. He worked for the BCCI as a physio and worked with many Indian teams, including IPL. Then he served for the UP Cricket Association and whatnot. So, not speaking much about him because he is a stalwart in this profession. So, may I request Dr. Vaibhav Daga to share his expertise or present the paper. Dr. Vaibhav Daga, if you can listen, please take the podium. Dr. Vaibhav ji. Dr. Vaibhav ji, please unmute your mic and video.
Hi, Subir. Just a second. I'm just on a call. Just a second. I'm just coming back.
Yeah. Please take your call. So meantime, Subhiji, you can take any question from the chat box.
I don't think if Hafiz is okay, then there is no any other question. What about the exam? Is it today?
No, it's not today, guys. Don't worry. So after
the question there related to nutrition, what can empty stomach cardio and weight training करने से क्या problem होता है सुबह में? So this is one thing. Every athlete, and मैं सिर्फ स्पोर्ट्स पर्सन के लिए बोल रही हूँ. इन जनरल अगर आपको वेट लॉस करना है, फैट लॉस करना है, आप मॉर्निंग वॉक के लिए जा सकते हो, आप अपना कार्डियो कर सकते हो. बट व्हेन आई एम टॉकिंग अबाउट स्पोर्ट्स पर्सन, आप खाली पेट अगर ट्रेनिंग करोगे सुबह में तो आपको जो ग्लाइकोजन स्टोरेज है वो डिप्लीट होता है, ठीक है, और उसमें आपको थकान जल्दी होने लगेगी. तो आपका जो रेगुलर ट्रेनिंग सेशंस होता है वो आप उतना लंबे समय तक कंटिन्यू नहीं कर पाओगे. तो फॉर कॉम्पिटिटिव स्पोर्ट्स पर्सन, मॉर्निंग ट्रेनिंग शुड नॉट बी एम्प्टी स्टमक. आपको कुछ ना कुछ खा के, एंड स्पेशली मॉर्निंग में अगर थोड़ा कार्बोहाइड्रेट खा के जाएंगे, सिंपल एक फ्रूट खा लो आप, या एक स्लाइस ब्रेड का ले लो पीनट बटर के साथ में, जैसे भी, या जैम के साथ में भी एक ब्रेड ले सकते हो. लेकिन आपका कार्बोहाइड्रेट लो नहीं होना चाहिए, क्योंकि उससे आपको थकान जल्दी होगी, आपका ग्लाइकोजन स्टोरेज खत्म होगा, जो आपके बाद में ट्रेनिंग और कॉम्पिटिशन को अफेक्ट करेगा. सो दिस इज ओनली फॉर स्पोर्ट्स पर्सन. लेमैन जिनका फिटनेस गोल अलग होता है, किसी को फैट लॉस होता है कुछ और, उसके हिसाब से फिर हम प्लान करते हैं उनको क्या खाना है या नहीं खाना है.
I think very good answer. Without any food, one should not go for any workout. This is the main breakfast, early breakfast, the pre-workout breakfast. You must have it. Without that, you will be nowhere. Then there is, madam, another question. What can we nutrition suggest to badminton player in case of ACL reconstruction after 2 months of surgery or the ground training?
ओके, सो ACL रिकंस्ट्रक्शन के बाद में डिपेंडिंग ऑन आपका सर्जरी कितना सीवियर इंजरी को लेके था, आपका रिहैब टाइम आपके डॉक्टर्स ने कितना लंबा सजेस्ट किया है. लेकिन अभी जो न्यू इमर्जिंग एविडेंस है उससे रिलेटेड, एक तो आपको अपना थोड़ा प्रोटीन इनटेक एडुकेट रखना पड़ेगा. दूसरा, कुछ स्टडीज है जो कोलेजन को सपोर्ट करती हैं, तो वो आपका जनरली, अगर आपका मसल टेंडन में इंजरी है, लिगामेंट्स में है, तो कोलाजन आप थोड़ा सा यूज कर सकते हो. जनरली 15 ग्राम का डोज होता है कोलाजन का, लेकिन उसको विटामिन सी के साथ में लेना है. आपको अपना विटामिन सी इनटेक ज्यादा करना पड़ेगा, क्योंकि वो भी कोलाजन बिल्डिंग में हेल्प करता है. वो चीज आपको ध्यान रखनी है. कई बार क्या होता है, सर्जरी के बाद में लोग अपना मिल्क इनटेक कम कर देते हैं. तो आपने देखा होगा जनरली डॉक्टर्स है कैल्शियम का टैबलेट प्रिस्क्राइब कर ही देते हैं. तो आई टेल देम कि रादर देन टेकिंग कैल्शियम टैबलेट, आप अपना मिल्क इनटेक को एडुकेट रखो, एडिक्वेट. और दूसरा, जो फ्रूट्स, नेचुरल फ्रूट्स वाले जो जिसमें आपको मल्टीविटामिन्स और मिनरल्स मिलते हैं, वो वाला चीज प्लीज ट्राई करो. तो एक जो है विटामिन सी, सेकेंड इज कोलाजन. अगर आप कोलाजन सप्लीमेंट ले सकते हैं तो. नया एक और जो राइजिंग एविडेंस है दैट इज जिलेटिन को लेके. लेकिन इंडिया में मेरे काफी एथलीट जिलेटिन लेने को रेडी नहीं है बिकॉज वो वेजिटेरियन सोर्स नहीं होता है हीलिंग के लिए भी। तो उसकी जगह कोलाजन भी जनरली नहीं है, लेकिन उनको जिलेटिन से यही लगता है वो बोन से ही बना हुआ। कोलाजन इज ऑल्सो नॉट ऑल वेजिटेरियन, लेकिन कोलाजन has been found to be very effective in after the reconstruction surgery.
So I think
Vaibhav is ready.
Yeah, Vaibhav sir, Dr. Vaibhav.
Yes, I am. Yes, I am.
Yeah, please.
Just have to start my video. Just a second. Hi, everybody. Hi, Subir. Hi, Vikram. Hi, all the people who are present here.
Yes.
Sorry, guys. I've just been a little bit tied up in between the tournament, so it's a bit of a tough time to adjust the timing because we just finished a match yesterday and it's a rest day. And as you know, after the match, it's more of recovery time for all the players. So the physios and the support staff are the most busiest after the match. Sorry for that, for making it a little bit delayed. Hope I'm not too much delayed.
Please share your screen.
Yeah, just a second. Is it? Can you see my screen?
No, not yet, Vaibhav. Yeah, now this is visible. Yeah, please. Yeah.
Hi. Yeah. Anything, Dr. Vikram, Dr. Subir? Do you want to start, or should I start directly? I mean,
Yeah. Start directly. I think it is.
Yeah, please start. Please start.
Yeah.
Yeah, it is very clear.
All right. Good afternoon, everybody. I'm here to speak about injuries in cycling. As Dr. Vikram has given me this topic to talk about the injuries about cycling as a sport. Cycling as a sport, as you know, bicycle-related injuries, what we are talking about. Bicycle is a wonderful form of exercise and sport, but as with any activity, it carries a risk of injury. Bicycle riding is a popular form of recreation among persons of all ages. Related injuries cause significant morbidity and mortality. Most injuries occur in, as per a study done in 1994 in the United States of America. Most injuries occur in males and are associated with riding at high speed. Most serious injuries and fatalities result from collisions with motor vehicles, because usually there is the cycling is usually done on the roads, and the risk of collision with the motor vehicles is pretty high. Then superficial soft tissue injuries and musculoskeletal trauma are the most common injuries. Head injuries are responsible for most fatalities and long-term disabilities. As we know, head injuries these days related to anything, any sport. I mean, even in cricket, for example, we have come across concussion substitutes. Footballers are looking at, it's a team sport, but concussion is the major issue when you talk about head injuries. We will talk about it a little bit later also. Okay. Most common cycling injuries, as you can see in the picture, and as per the breakdown in the injury pattern, injury incidence breakdown, if you see males versus females, neck injuries are 42.2% in males, 54.9% in females, 29.6% of the knee injuries, hands, and so on and so forth. I mean, if you see the most common injuries is the neck, then comes the knee, and then goes on with the hands, the iliotibial band, the feet, the back, the hip, the Achilles. So these are the various injuries, and if you can see, it's the way the cyclist mounts his own bike and the way he is riding depending on that, the injuries do occur. And commonly, as you see, the neck issues are basically possibly due to the overuse or due to long rides on the bicycles, what they do. There are other injuries like the saddle sores, the urogenital area, the foot numbness can happen. So these are basically because as a sport, as a cycling as a sport, you definitely do a lot of long rides, and these injuries are kind of more commonly seen in people who are professional cyclists or cycling for recreation also. I would call them as amateurs or professionals, whatever. So continuing with the cycling injuries are an unfortunate part of most riders' relationship with the bike. Some common issues experienced by cyclists can be treated and avoided with the home care. Body is one connected web. Understand, not every injury is rightly coming from that particular part which is showing the symptoms. All right, the actual cause may lie somewhere else, up the kinetic chain, or somewhere else where you need to really treat the cause. So if with your home care, with people who are cycling, or right now I'm talking to the group of trainers and teachers who are basically developing athletes in different sports. So if you cannot definitely deal with that particular injury on your own, it is very much suggested and recommended to see a professional like a physiotherapist or an osteopath or a chiropractor to see where the cause of the pain is coming from. If the symptoms don't resolve with the remedies you're giving at home or at your own institute, or common at your institute or at your academies, and so on and so forth. So as I said, impact injuries are the injuries which cannot be avoided as such, but definitely they can be rehabbed or got back very early. Crashes are an unfortunate side effect of cycling. The obvious advice is to seek medical attention if you have crashed heavily. Even if no bones are broken, you may have hit your head. Concussion can require significant rest and is not to be taken lightly for sure. Concussion is the in thing. There's a lot of research going on in the sports medicine world about concussion, and that's the most important thing what you have to look into when you see that there is an impact injury on the head. So there are programs like the SCAT5 is the assessment tool which we usually follow in team sports. Definitely that could be followed in bicycling also. If one of you is if one of you is right there during that impact of the head, and if you could assess them by going through the SCAT5 and seeing if the athlete is concussed. Of course, he has to be removed from the scene. He should be definitely have to given a significant rest, as I have mentioned in the point there. So it's very important to deal with this very carefully and precisely. Then we talk about knee pain. Again, the knee is the most common site of overuse injuries in cycling. I mean, it's obvious your knee is the most active part when you're bicycling. Involve pain around the kneecap, the iliotibial band friction syndrome. Shoe implants, wedges beneath the shoes, and the cleat positions may help prevent some injuries, some overuse injuries in the knee. So what is the iliotibial band friction syndrome? So usually people who may understand, I believe, are there any physiotherapists in the crowd, Doc?
Yeah, there
are. Okay, so you would understand what the anterior knee pain is like. And anterior knee pain is basically due to the kneecap and due to the imbalance around the kneecap. So the imbalance can be caused due to imbalance in the muscles in the quadriceps. There are 4 muscles in the quadriceps, as you know. The quadriceps like there is a vastus lateralis, the vastus medialis, vastus intermedius, rectus femoris. So these are the four muscles, and usually sometimes many a times we call as the kneecap is on the is in the groove of the femoral trochlea. So once you it basically a train riding on the track. So if the train is derailed, and why does it get derailed? Due to imbalance in the muscles, and that imbalance can come due to overuse, due to repeated stress onto that particular knee part because of the bicycling, and that can be because of the cycle itself, because it's probably you haven't bike fitted yourself. That can be one of the reasons. Similarly, iliotibial band syndrome. Iliotibial band is the band which runs right from your lateral hip joint to the lateral knee joint. So it's on the outside of your thigh, and that also could affect the kneecap mechanics and would give you pain in the knee. So you have to deal with them. So how do you deal with them? Of course, I'm going to talk about it later, but I'm just going through the injuries initially. If anybody has questions, please do feel free to ask in between also. Yeah, coming back to the head injuries, it's similar to the head impact injuries. One of the most common injuries suffered by cyclists can be anything from a cut on the cheek to a traumatic brain injury. Wearing a helmet may reduce the risk of head injury by 85%. So the most important part about cycling is the equipment. The cycle itself has to be fitted to your posture, to your position. Similarly, the protective gear like the helmet, the gloves, the shoes, the proper cycling shoes, the padded cycling shorts, a proper t-shirt are the things which are the gears what you should have properly protective and properly fitted with you. So if similarly, if the helmet is there, it reduces the risk of head injury by 85%. So that's a big thing. And so it's always recommended whenever whoever is into cycling for recreation or sport should always have these protective equipments with them and be wearing them when they are cycling. The next is the neck and the back pain. Cyclists most likely experience pain in the neck when they stay in one riding position for too long. I just mentioned this before in the talk. Improper form also leads to injuries. If the handlebars are too low, cyclists may round their backs, thus putting strain on the neck and the back both together. You can just imagine the position. I mean, if you want me, if I just go back to the picture there. So if this distance between you can see my pointer?
Yes.
Yes, visible.
If this distance between the seat and the handle is too long, the rounding of the back happens to much more. You're much more lower, and at the same time, to look up, you have to strain your neck further there. So the injuries to the neck are common in that scenario, and as well as the lower back. Tight hamstrings or hip flexor muscles can also cause cyclists to round the arch back, which causes the neck to be hyperextended. I just mentioned that. I mean, tight hamstrings, again, tight hamstrings, what will the tight hamstrings do? Any physios on the house can answer this question. What would the tight hamstrings do?
Sir, anterior pelvic tilt.
Okay, anything else? Will it be anterior or posterior?
Posterior.
Thank you. So the posterior pelvic tilt will cause a strain onto the lower back area, right? And they are forced to cause the rounding of the back. Even if you're sitting, I mean, right now I'm sitting here and I'm sitting on my, if I'm sitting in a posterior pelvic tilt, and if I'm sitting relaxed, usually you're sitting in a posterior pelvic tilt, you're sitting on your pelvis, you're sitting on your tailbone. You're not sitting on your sit bone. Similarly, the lower back is going to be strained because of that. And a repetitive strain there again will cause an overuse injury and causing the back pain. Similarly, because of the back being like that, you try to as I said, because you have to watch while you're cycling and you have to look forwards. You try to look forwards, and that causes a lot of impact on your neck and the upper back muscles also. So that is definitely going to be an issue. Stretching these muscles on a regular basis will create flexibility and make it easier to maintain proper form while you're cycling. The next sort of injuries are wrist, forearm pain or numbness. Cyclists should ride with their elbows slightly bent, never with their arms locked or straight. So again, as I said, as you can see in the picture rightly, you have to have a bend in the elbow. If the elbow bend is not there, it's going to again impact your elbow as well as the wrist. Because if you lock the elbow and you're too much leaning forward, again, or you're not able to reach the handle properly, if the bike fitting is not proper, it is going to cause a lot of stress on your elbow as well as the wrist joint. So definitely, see, ultimately, what I understand, looking at the cyclists, what I have come across, and if you don't have a proper fitting bike and a proper equipment, the equipment is the cycle here, and the equipment, what you wear, the helmet, the gloves, the shoes, everything. If they are not proper, most of the injuries can be prevented with a proper bike fit and a proper equipment. But if that is not there, these are the problems what you face. So never with the arms locked or straight. Hit bumps in the road, bent elbows will act as shock absorbers. That's the most important thing. The elbow shock absorption is very important because you're riding it on a road, and definitely in our society, in India, the roads are not the best for sure. It's not only about India. Wherever there are going to be bumps in the road, there are going to be uneven surfaces, uneven roads, and that can cause a lot of shock onto the elbow, onto the wrist, and the nerve surrounding it. So two common wrist overuse injuries, it's called a cyclist palsy and a carpal tunnel syndrome. So these injuries have to be looked into. So to prevent them, as I said, you should have a proper bike fit. Next is urogenital problems. Common complaint from male riders who spend a lot of time riding is pudendal neuropathy, a numbness or pain in the genital or the rectal area. All right, caused by compression of the blood supply to the genital region. A wider seat, one with padding, a seat with part of the seat removed, changing the tilt of the seat, or using the padded cycling shorts will all help relieve pressure. Or then you can basically have bicycles where there is no seat. So these are the standing cycles which they have tried. I'm not sure how do they work. I've never come across one, but if they are using it somewhere in the world, obviously there is some kind of a use of it. So definitely it's going to help in the long run, possibly if these urogenital problems are causing a lot of issue and you're not, then it's definitely got to shift to a standing cycle. Saddle sores. Hello, who's this?
No, Vaibhav, sorry, I have muted. There was some disturbance. Please go ahead.
Yeah. Okay. Saddle sores. Many joke about it. It's definitely a joking area for sure. Tail of a saddle. I mean, there was in London Olympics 2012. It came to a lot of in the Olympics. Basically, most of the British cycling company or the team were having saddle sores. So, but any sore raised area of skin around the buttock or undercarriage and caused by contact with saddle would sit in this category. Treated by taking off and keeping the area dry and clean. Prevention is all about saddle and cycling shorts, as we have mentioned before. We come to the foot. From the saddle source, from the urogenital area, the knee, we go down to the foot, which is again a very commonly injured area. Hot foot, a burning sensation, numbness or pain in the underside of the foot is common. Foot numbness can be due to exertional compartment syndrome, arises from increased pressure in the lower leg and resulting compression of the nerves. The diagnosis is made by the pressure measurements and is treated with surgical release if it is a pressure compartment syndrome. Unfortunately, we don't have many equipments around in India to measure the compartmental pressure. But if we could do that, that is the best way to measure this. And definitely, it's basically a surgical emergency. So I mean, the doctors on the group on this platform can appreciate that how emergency is this exertional compartment syndrome. All right, that's about injuries. So how do we prevent them? What do we do? As I said, of course, the equipment is one of the parts, but yes, conditioning and strength, working on the strength and the conditioning of the body or the musculature which is used in cycling would definitely help them to ride longer and stronger. So a body conditioning exercise is in any exercise that improves a physical attribute and may include cardio exercise to burn fat or resistance training to tone muscles. In a nutshell, conditioning is the way body adapts to training overload. For maximum benefit, the overload needs to have a specificity related to the training aims, be progressive, and include time and recovery and adaptation. So basically, this is conditioning in general, what I'm talking about. But cyclists need specific conditions in the muscles, what they're going to use when they're cycling. So it's about the lower body, it's about the back, it's about not having too much of tightness in your upper back, in the neck area. So these are the things which we need to look into. So how do we do that? And that's this, if you have a proper strength and conditioning, the performance in cycling definitely can improve. So I'm not going to go details into the performance. I'm just going to go through this slide very quickly. The optimization of athletic performance is a matter of importance for all sports, and for specific fields such as cycling is mainly related to the measurement of time or distance. So a cyclist measure their performance basically in time and distance, and how soon and how quickly they can get to the other side, or how much of a distance they can cover in a shorter time. That's what they're looking at. And how can that be done? By keeping the injuries at the bay, performing better. How do you keep the injuries at the bay? Don't let the overuse injuries affect you. How do you do that? You do it by basically having a good conditioning program, a good strength program, which will help you to be much more effective in your cycling performance. So cyclists are asked either to cover fixed distances, as I said, to go as far as possible in a fixed amount of time. The improvement of performance is based on efficacious training, which aims at the development of motor strategies, including aspects such as energy expenditure and mechanical implementation. So that's there. Also includes strength work in their training routine. So what are the strength work we look into? A few exercises, which videos I have put here. You can see this is a goblet squat, which is going to basically work on your quadriceps and the glute muscles. So it's basically you use a kettlebell in that position, and just do a normal squat, as you see that gentleman is doing there. Ensure that it is in a proper way it is done, and anybody who are seeing the cyclists can start these common exercises. Definitely it can be individualized further, but these are the very common exercises. What I'm telling you here would definitely help every cyclist. Then there are lateral squats. We talk about goblet squats, then there are lateral squats. So what is going to help is basically, again, the muscles. What you targeted is you can do with kettlebell, or even you can do it with a dumbbell. Again, hamstrings as well as the glutes are the major muscles which are recruited in this particular form of exercise. The starting position is this. And what you do is not about bending laterally, not going down laterally, but the hip hinge. This is the most important thing, the hinge of the hip. I mean, I'm just taking this. Sorry, yeah. If you see the hinge of the hip, this angle is more important when you are doing a lateral squat. It's not about how deep you bend in your knee. It's about how well you hinge your hip and touch the weight to the floor. Better done with the kettlebell. And basically, this would usually give you a stronger glutes and the hamstrings, which are important muscles during cycling. Then is a stiff leg deadlift. Many of you would have, many of you who's listening to this talk right now understand about these exercises and are experiencing those exercises on your own or with your trainees. So it's the muscles of lower back, hamstrings, glutes. These all are recruited when you do a stiff leg deadlift. It is a double stiff leg deadlift. This can be done in a single leg deadlift also. Progression can be done that way. Again, the hinging of the hip is important more than the bending of the back. If you see the gentleman's back is pretty straight and he's hinging his hip backwards, that's the most important part of this. Keep the back straight, push weight onto the heels, push hip backwards, keep the neck in line with your back, feet shoulder width apart. So that's how you do a stiff legged deadlift. Front plank to measure on the core, very functional exercise. Again, if you talk about the cycling, because you're in a position where you're leaning ahead on a road bike, usually you lean ahead, or any of the bikes, even in a mountain bike, you have to lean ahead. So your trunk has to be very strong. And the front plank is an exercise which would basically provide you a lot of strength and conditioning to your abdominal and the trunk muscles. I'm sorry, I don't know why this video is not playing. If anybody doesn't understand what the front plank means, I will definitely demonstrate it to you. Unfortunately, this video is not playing. I don't know what's the reason. Some technical issue there. Then there is a side plank here. And side plank is just coming onto your side and working on your oblique muscles of the trunk. It would definitely work on your hip muscles also, and definitely on your little bit of upper body, like the shoulders and the biceps in the upper body. So for the beginner, you can start it with being on the knee and ensuring that these the obliques do give you a good strength and conditioning and the stability. You have to ensure that the body is in straight line, and you can progress to the feet if you are well versed and well aware of the exercise. If somebody is in an advanced position, if you can see that the trunk is a little bit tilted, like your belly button is a little bit tilted towards the ground. So it will give you a lot of more recruitment of the oblique muscles, and that helps to be during the cycling. Okay, similarly, we talked about the strength. We have to talk about the mobility routines. These are the equipments what you can use for mobilization of the whole body. This is called the peanut ball. So how can we use the peanut ball in different? The peanut ball is basically used to release the tight upper back muscles of your spine. I'm just going to mute this video, but that's where the peanut ball is kept to really work on your upper back muscles, the tight muscles, which are definitely going to be tight when you come after a long bicycle ride. And because of it, constant bending over and reaching for the handle, it definitely would work, give you tightness there. So that tightness could be relieved by doing this peanut ball exercise. Rolling on the peanut ball, you can, if you don't have a peanut ball, you can use a simple tennis ball at that particular area on either side of the spine. Definitely, you can use the foam roller if you don't have the peanut ball. A small mini roller you get, that also could be used. If nothing is there, you definitely try and use, even at home, in Indian home households, we have the pill roller with which we make the chapatis. That also can be used to release the upper back tightness. Thoracic spine rotation, it's an mobility exercise, which we should be demonstrating in this video. So as you go through these, through the video, you can see that this particular athlete will demonstrate. So you hold the foam roller right in between your knees on one side, so that your hips are locked. The important position is to lock the hips. You should basically work on your thoracic spine, which is the upper back spine. And that's a beautiful rotation, what you get of your thoracic spine. And that helps the thoracic spine to be very mobile and effective.
Hello, please stop your mic.
Does somebody want to ask a question, Mr. Subir?
Not a question, actually. I think they're speaking to their family.
Okay.
Mr. Rakesh Kumar, please mute your mic. Mr. Rakesh, I'm muting you and you are unmuting yourself again. Please mute yourself. Sorry, Vaibhav, please continue.
Can we go ahead? Yeah, thanks.
Yeah.
Thanks, Doc. So that's the exercise which is very, very responsive, very, very effective in the rotation and the mobility of the thoracic spine. Thoracic spine is the key these days. I mean, a lot of evidence has come across that it's not about when you usually have a lower back pain or a neck pain, it may not be it may not be locally present at the lower back or the neck, but it is all coming from the restriction in thoracic spine. And usually thoracic spine gets a lot of restriction due to the attached rib cage, what is there. So it has to move, the rib cage has to also move properly to give an effectiveness in the mobility of the thoracic spine. And if that really works well, you can have your good mobility, and that helps you in all sports forms. I mean, I'm not talking about only in cycling, but every sport, thoracic spine is very important. The mobility of thoracic spine is very important. So this is the way you mobilize the thoracic spine. This is definitively a hamstring stretch, very effective way of doing it. People definitely do a lot of hamstring stretches. You need to have a good flexibility in your hamstrings when you're bicycle riding, for sure, because depending upon your seat height, how much of a hamstring involvement happens depends upon definitely on your seat height. But there are ways to do hamstring stretches. I'm sure most of you all know what is a hamstring muscle and how do you stretch it. You have seen a lot of people bending over, reaching for your toes, holding the toes, trying to stretch the hamstrings, but it is causing so much of a back loading. And the lower back loaded in that while you're stretching the hamstring is not a good thing to do. So very effective way of doing a hamstring stretch is the way it is shown in the video. You stand up straight. You just have to be erect, be tall from your lower back, tall from your torso, and push your hip a little bit behind, like kind of do a purposeful anterior pelvic tilt. And you will find you yourself can right now get up from your chairs. I'm sure you've been sitting for a long time, and try and do this hamstring stretch on your own. You will find it very effective. For the matter of fact, I will demonstrate it for you. Are you guys able to see me while I'm standing?
Yes, sir.
Yes, sir.
Yeah,
Yes,
so
sir.
I mean, if you just lift your leg up, keep it on a chair like this. You can see my leg also.
No, sir.
No, sir.
Now,
Vaibhav, Dr. Vaibhav,
yeah.
actually the pick is very small. So maybe it's just impossible to really find it out.
Let me see myself first.
Put a spotlight onto him, Subir.
Pardon, sir?
Spotlight on Vaibhav.
Now?
Yeah, it is clear now.
Now it's clear. Okay, so if you can see that, I'm standing tall here. I'm just giving you an example of how you can effectively stretch. Everybody can do that at your ends. Get a little bit active. I'm sure you've been sitting on this conference for a long time. So just be tall there, keep your torso taller, keep your chest up, and just push your bum behind, and you'll feel a good hamstring stretch. You don't need to pull your toe towards you. Your toe can be pointed towards the backrest of the chair, and you can feel a good hamstring stretch. So it is not necessary to bend over, touch your toes, loading the back and the upper back. That's not required. For effective hamstring stretch, even this much of the fascial stretch is very, very, very effective. So that's the way you can be innovative. You could understand what are the ways to do it. You don't really need to do a lot of things to get the stretch in your hamstrings, for the matter of fact. Going ahead is the hip stretch, the hip musculature, the hip capsule, everything gets stretched in this. It's very effective. Again, you just place yourself, the leg, which has to be stretched. So he's stretching his right hip joint here, if you can see, and it's just, he's trying to drop down from that position. So if you can see it from the front also, they show it briefly in the front. This is how straight you should be. And you can drop this knee down. As you drop this knee down, you get a beautiful stretch into your hip joint, and the hip musculature is pretty mobile with this kind of a stretch. Got it? Next one. Yeah, trigger ball, glute release. This is the trigger ball, what we talk about.
Glutes, and really helpful in it.
You just basically get onto a sore point if you don't have a trigger ball, you can use a normal tennis ball also, which is pretty effective to release a trigger point onto your glute medius and the glute maximus muscles there. So that's the way you do it. You use the trigger ball, sit on it. That's the right way to do it. There it is. If you can see that, you will definitely feel a point which is more sensitive. You definitely stick onto that particular sensitive point and move it around on that particular point. You can hold it there, possibly do some dynamic movement of the glute again by holding it there also. So that's the effective way to mobilize and get a good mobility in your gluteus muscle. Yeah, okay. I'm not going to really get into the nutrition part of it, but I'm just going to very quickly run through this. There is a nutrition expert on the panel here, and she would have definitely talked more about it when we talk about recovery. Nutrition is the way to recover from the cycling, post-cycling exercise or training or an event. So reduce the soreness, injury, and fatigue that result from training and exercise. Failing to recover can cause and aggravate injuries. Overtraining, only elite suffer, that is a myth. So how can we speed the process of recovery? Stretching post, ice baths, there is not a very clear part about it and clear evidence to the ice baths at this moment of time. Yes, it is very anecdotal. A few people would like it. Active recovery is the best way to recover. All right. What is an active recovery? Basically, you got to be active at a very lower heart rate. Just get into the motion. Be more active rather than a very passive recovery. All right. Compression clothing, again, debatable. Yes, compression clothing there is a recovery clothing which we use. The compression clothing, like the skins, as they call it. That's one of the other ones to recover properly. Yes, that's the most important recovery factor is the nutrition. It's talking about nutrition, your hydration. These are the two things which definitely. And the second most important thing for me for recovery is the sleep. I believe, according to me, sleep and nutrition, these are the two factors which you need to be focusing on when you're recovering from this. And if you recover well and you after the recovery, you go for another ride, that's the time when you really will be performing better and keeping the injuries at bay. Okay. So take home is strength and conditioning is the key, 2 to 3 times a week, not more than 45 to 75 minutes. Recovery, most important thing is fitting your bike. Thank you very much. Those are my details. If you want to get in touch with me at any certain stage, you definitely can follow me on my Instagram and my Twitter, on my Facebook, and definitely that's my email.
Please, sir, WhatsApp number, sir.
Sorry?
Sir, WhatsApp number.
I'm sorry, I won't be able to share the WhatsApp number.
Guys, you can connect.
WhatsApp number, sir. Mobile.
Guys, you can connect Vaibhav through his email. Because
that's the best thing, but definitely the social media things will be the best way to connect to me. I will definitely reply, if not immediately, but I will reply.
I think there are a couple of questions.
Yeah.
If you can see the chat box.
Okay, chat box. I'll have to open the chat box. Okay, I'm opening it.
Sir, please clear if cycling causing any urology related complications. Farooq Ahmed. I think already in the slide he has spoken it is.
The urogenital problems are definitely common in cycling. You have to rule it out if it's more serious. If you think so that there is a urology issue which is happening, there is definitely that's why they say the males suffer the most. I mean, there are urology related issues and can happen. I cannot deny that it cannot happen. Those complications have to be ruled out and proper reference should be dealt with.
The other question is from Leon Purian. Any contraindication for such hip stretch?
Any contraindication for such hip stretch? Is it safe on knees for cyclists with knee pain? Okay. The one which I showed, Luke?
Yes, sir. Yes, sir. The one which you were showing.
Yeah, there can be. If the knee is, you can modify the stretch to a pigeon stretch, possibly. If the knee is more giving you an issue. If there is a pain somewhere with the from the knee, you can go to a pigeon stretch. I know, I understand. Are you a trainer?
I'm a physical education, sir, but I'm a cyclist. That's why I was asking.
You're a cyclist yourself. Okay. Do you know what's a pigeon stretch?
Yes, I know.
Yeah. You can move to a pigeon stretch, or possibly you can move to a stretch for your glutes lying on your back itself by entangling and causing a figure of 4 stretch and pulling. So that also can be very effective if you have knee issues.
Oh, sir, actually, it's not for me. It's for a trainer of mine.
Yeah, that's what I said. If there is a knee issue, then definitely you can modify the stretch. The effect has to come onto your hip, the hip capsule and the hip musculature.
Okay, sir. Thank you.
Last question: can trigger ball used for releasing spasm?
Yes, absolutely. Trigger ball is meant for that. I mean, trigger point doesn't release the spasm as such, but it reduces the sensitivity of the trigger point in the myofascia, and in turn, the resultant of releasing the trigger point, making the trigger point less sensitive, the myofascia gets a little bit more flexible, and that's how it will help to reduce the spasm.
There is another question. Trigger ball exercises may be recommended to the person driving any vehicle.
Trigger ball exercise. Yeah. Why not? I mean, if you find there is a muscular tightness or there is a muscular imbalance in that particular person who is into driving position, who's sitting for a long anytime, definitely. I mean, it can be the trigger points in your gluteus muscles. It can be trigger points in your hip flexors. It can be trigger points in your TFL muscles. So yes, you can definitely use this for anybody who has a sitting job. Not only vehicle driving, even the people who are sitting a lot. I mean, you yourself have been sitting since morning. Definitely, you can right now. You will feel tightness somewhere in your hips and back. if you use a tennis ball which is present at your end in the at home, you definitely can use it right away and see the effect yourself.
It's a wonderful session, Dr. Vaibhav. I think there are quite good compliments. Even it is really good because you have spoken about the injuries, then how to rehab, and that is the best part. Speaking absolutely with the injuries, it doesn't make how to really recover. That is much more important. I think I must really, before giving the platform to Dr. Vikram Sharma ji, I must tell everyone that Dr. Vikram Sharma ji, in yesterday night we are speaking at the it is 12 p.m. in the night. So you can understand the effort which he has taken. A huge round of applause for Dr. Vikram. You did a splendid job. Really, it is commendable because for last 2-3 months he was after the course. So thank you, and Vikram Sharma ji, and over to Vikram Sharma ji, please.
I think there is a question from some Mr. Amjad. He has raised his hand. You can ask, Amjad.
Sir, my question is related to stretching of hamstring from prone to SLR position. Is it still feasible or validated? I mean, it's validated to do the stretch in this position because it will increase the posterior pelvic tilt. So, do you still advise to use this position, conventional method, or the way you taught us today?
You're talking about supine position, not prone.
Yeah, sorry, supine, from supine.
Supine position, there is an effective way of doing that also, but at the same time, if you can keep your pelvis in an anterior tilted position and be more effective, try not to pull when you're lying down onto your back and trying to pull the hamstring. That's what people usually do, pull the leg towards you. The leg towards you should not be, I mean, you're right there and you're trying to pull the leg up here, right? That's what you're saying. Yeah, so I would say yes, you can still do it, but there is a way to do it again. You should not be doing the ankle dorsiflexion in that stretch. You try to keep the ankle into plantar flexion, so it is much more effective on the fascia along the hamstring muscle, and it does not go onto the neural part, which gets more effective when you do the dorsiflexion of the foot, of the ankle.
Thank you, sir.
Yeah, pleasure.
Okay, Vaibhav, thank you. Thanks a lot again. And now you can stop sharing your screen. Yeah. So thank you, guys. And indeed, this was a pleasure for last 11 days working with you guys. And sometimes this has been challenging also because to keep my surgeries according to this, because I have to be there by 4:30 to cater you all. And this has indeed been pleasure because you guys were very disciplined and very curious, very meticulous. And we as a faculties, we wish that you have learned a lot from this course. And the basic thing is that the same knowledge must be applied to your practical field. So I'll give you some of the instruction before taking a concluding remarks from our teacher, Dr. Ashok Ahuja sir. So guys, as far as exams are concerned, we are going to give you around 3 weeks time. So you can go through all the videos. We will provide you some of the PPTs also. We are trying to get all the PPTs from each and every speaker, but you can understand that there may be some of the speakers have reservation to provide their PPTs. So maybe you may lack some 2 or 3 speakers PPT, but videos of all these lectures would be provided to you. And along with that, we are going to provide you some more videos related to all the sports injuries. So you can go through them. And I'll put other information on the WhatsApp group also regarding the exams and what would be the pattern of exam. And please do remember, as I said on day 1, that there are chances of failing the exam also. So let me tell you guys, there's no intention to fail someone, but being as we want you to learn a lot from this. So we want you to be very meticulous on watching videos, going through the PPTs, and just utilize the course as much as you can. So thanks a lot, guys, again for being here. And just one more thing, that this is not the end of this course. This is like a start of a journey. So we will remain together and we will remain in touch. And with this course, we have gathered so many things also, that we should focus more on sports rehab, nutrition again do require any separate thing. So we will keep working on that and we will keep you intimated for this. So do we have Dr. Ashok Ahuja with us right now? Subhiji, can you spot him? Ashok Ahuja sir is with us.
Let me check.
Yeah, please. Because
It is already quite late.
okay, no problem. Because Dr. Ashok Ahuja was attending our session almost each and every day, and he was giving personal feedback to me. So I'm thankful to him also, and all the faculties. Guys, all the faculties are very busy people in their practices and in their work. Some of them were orthopedic surgeons, so planning their surgeries according to this. Like even Vaibhav was very much busy today, but as he committed to take this lecture, so he spared his time. So Vaibhav, thanks a lot again for this. And all the faculties are like some of the physiotherapists, physical education teachers, and some of them are sports physician. So I'm thankful to each of them. So guys, signing out now. We are ending this course session as of now. This was the last day, and today this was the 11th day. So I will.
Dr. Vikram.
Yeah.
Dr. Vikram, sorry to interrupt, but I just want to thank you, and I just want to request you to have some offline courses also, as these are the courses which I like the most. Means ये जो है ये ऑनलाइन से ज्यादा हमें ऑफलाइन हेल्प करेंगे.
हाँ अनुज बिल्कुल, पर ये समय परिस्थिति ऐसा है कि अभी कोरोना के टाइम पे हम लोग कर नहीं सकते थे. We organize a conference also in a year, so I'll keep you guys intimated about each and everything, and this will be a pleasure to spread the education and the experiences. I understand that we had a BLS session, और BLS session कभी complete नहीं हो सकता without hands-on experiences. But at this point of time, we do have certain limitations. So this was the reason for that. So definitely I'll keep a note of this. So thank you guys, everyone, for being here.
Sir, thank you, sir. Dr. Vikram, Dr. Srivastava here.
Yeah, thank you, sir. Thanks a lot.
Okay, sir.
Thank you, guys.
Thank you, sir. Thank you very much, sir.
Thank
you.
To give
Thank
such
you
type of opportunity to learn something.
Thank you, sir. Thank you, sir.
Okay.
Dr. Vikram, thank you very much.